Hello. Am I audible?
Yes. Kamlesh, 1 minute, please.
Yeah.
Hi, Kamlesh.
Hello, sir. How are you?
All good.
Fine.
Good morning, Dr. Zareed.
Good morning. Good morning, Surendra. Hi, how are you? Good to see you.
Very good.
Kemcho, busy?
How are you?
Keeping busy with the pandemic?
Yes.
Sir, we are already live on YouTube.
We are live now.
Yeah. Can we start?
Kamlesh bhai.
Yeah, start. Okay. Good morning, friends and colleagues. As per the tradition of Bombay Seaward Medical Association, we are back today, the first Sunday of the month, with a very interesting and insightful webinar. As an unrelenting second wave of COVID-19 continues engulfing us, today's webinar will focus on new clinical manifestations we have been observing. In this second wave and various vaccines that are now available to help combat this pandemic. Today, we have two very distinguished speakers who are true COVID warriors who have been at the forefront of the fight against COVID right from the early days. Dr. Jarir Udvadia, a renowned and well-respected chest physician who needs no further introduction. He will enlighten us on the A to Z of various vaccines that have currently been approved and are being administered globally for COVID-19. Dr. Tushar Shah, a teacher par excellence, will throw light on current clinical manifestations and management of COVID-19. We are grateful to all the panelists who have joined us from all over the country and taking part in the question answer session. I am thankful to our scientific conveners, Dr. Anil Mehta and Dr. Jawahar Mukherjee. We are fortunate today to be joined by Bombay Medical Union, Sir H.N. Reliance Foundation Hospital, GPA, FFAPI, the Bombay A and D Ward Medical Associations, and Jain Doctors Federation. I wish you all great health and now hand over to Dr. Anil Mehta to further today's proceedings.
Good morning, viewers. I am Dr. Anil Mehta, Clinical Secretary and Scientific Convener. Welcome you all to the Bombay Seaward Medical Association CME on first Sundays of every month over last 40 years. Every month, we bring in different relevant medical topics discussed by eminent authorities in the field of medicine. I today proudly announce we have none other than Dr. Zarir Udvadia to deliver a talk on most relevant awaited topic of COVID vaccine. The number of cases of COVID-19 are rising sharply in our city. It's almost a war-like situation. You all may agree that COVID pandemic management is practiced and governed by some common sense, some logic, some logistics, economics, availability of resources, social media, so on and so forth, and mixed up with science. To seek scientific answers today, we have a panel of eminent primary care physicians who are the real actual backbone of our healthcare system. They are invited from different parts of Mumbai and Pan-India. They are going to discuss, they have a panel discussion in our second session, moderated by eminent physician, Dr. Tushar Shah. The panelists we have Dr. Bharat Bhatt from GPA, Dr. Janak Shah from FFPI, Dr. N.K. Kumar, Dr. Alpa Thakkar from Chembur, Dr. Bhairavi Shukla Chira Bazar, Dr. Shaila Ansari Malad East, Dr. Rajni Gwalani Chembur, Dr. Preeti Shankar from Bangalore, Dr. Leela Ramlal from Kolkata, Dr. Sanjay Shah from Ahmedabad, Dr. Mita Gala from Jain Doctors Federation, Dr. Rajiv Shah, Marine Drive, Dr. Atul Mashur from Ketwadi, and other panelists from our Seaward Medical Association, Dr. Jawahar Mukherjee, Dr. Surendra Delia, Dr. Vibhakar Advari. Now, coming to the first session, it is my proud privilege and introduce Dr. Jarir Udwadia. Dr. Udwadia is a consultant chest physician, MD, DNB, FCCP USA, and FRCP London, attached to Hinduja Hospital, Bridge Candy Hospital, and Parsi General Hospital. He has struck a unique balance of combining a busy clinical practice, seeing more than 10,000 patients in OPD, with internationally acclaimed medical research. His special interest includes TB, MDR-TB, interstitial lung disease, asthma, pneumonia, bronchoscopy, sarcoidosis, sleep studies, and above all today, COVID-19. He is a prolific researcher and has over 190 PubMed Index medical research publications in the world's premier academic medical journals. He has been invited to deliver lectures at conferences and universities around the world on different forums, and several lectures at Harvard University, Boston too. He was the first one to report cases of totally drug-resistant TB from India. This stirred up intense medical and media attention in 2012 with 2,500 articles in newspapers and news sites across the world, including BBC, CNN, and likes, and a special feature on him in the prestigious Lancet. He was invited to join USAID India and TB Alliance and the Global TB Network to pursue global TB elimination. He has been advisor to WHO and was invited to Geneva on several occasions to help formulate the current TB and MDR-TB guidelines. He is on the core committee of doctors selected by our government of India to inform Bombay's COVID-19 pandemic situation time to time. In 2017, Open Magazine nominated him as one of their 25 top minds on his impact on public health. He had given 2 TED Talks, one on drug-resistant tuberculosis and other on COVID-19, both of which have been widely viewed. So here, may I invite Dr. Jarir Udwadia to speak on the light at the end of the tunnel, COVID vaccine, and all your vaccine-related questions answered. Dr. Jarir Udwadia, please.
Thank you, Anil. Thank you for that kind and generous introduction. Thank you to all my general practitioner friends for inviting me, Kamlesh, Bhairavi, Atul Bhai, all of you. I'm going to try and share my screen. Can you see that?
Yes, sir.
And you can hear me clearly, Anil?
Yes, sir. Absolutely.
Wonderful. So, who would have imagined over 1 year ago when a mysterious viral pneumonia sickened 7 patients at the Wuhan General Hospital? Not even the most pessimistic, the most cynical of us would have dared suggest that this would transform 1 year later into a pandemic that has affected 130 million and killed 3 million already. Now, as a medical community, we have done poorly when it comes to therapeutics that work in this pandemic. Hundreds and thousands of trials have already taken place in the last 1 year on hundreds of different drug options. And sadly, only 2, dexamethasone and possibly remdesivir, have found to be effective. In contrast, there's a huge list of drugs that have shown to be ineffective. And WHO just a few days ago released a strong directive cautioning against the use of ivermectin, so beloved by so many family doctors for some strange reason. So just my plug not to be using this drug at all. However, we've done remarkably well when it comes to the field of vaccine development. It's particularly heartening. It's a remarkable success story. The time sequence is really dramatic as well, because 7 days after SARS-CoV-2 was identified as the virus which caused COVID-19, Chinese scientists had already put out in the public domain the 30,000 letter genome. And 10 days later, just 10 days after that, NIH scientists began putting together the gene sequences that would become Moderna's mRNA vaccine, the first vaccine that was commercially available. So look, we've gone from identifying a new pathogen to an effective vaccine in a remarkable period of 11 months. Note that the fastest before this was 4 years for the mumps vaccine in the 60s. And HIV has no vaccine still after 4 decades of research. So that has been a remarkable success story. With these introductory words, let me begin my talk. As I said, the development of this vaccine or vaccines against SARS-CoV-2 within 1 year must rank as one of mankind's greatest scientific achievements, not just for the pandemic, but I mean generally. However, the real challenge, the real logistic challenge will be delivering the billions of doses that are needed worldwide. Now, why are vaccines so useful? Because they prevent 3 crucial things. They prevent severe illness, they prevent hospitalization, and they prevent death. So the race is on between vaccines and variants, which I will tell you a little more about. And let us hope for humanity's sake that the vaccines win. So currently there are 12 vaccines deployed and in use across the globe. Actually in use. 70 more are in phase 3 trials. More than 175 are in the preclinical or clinical trial stage. As of April 1st, that's just a few days ago, the Bloomberg Vaccine Tracker says that 520 million doses had been deployed across 140 countries. So we are vaccinating people at a rate of 13 million doses a day. You may think that's fast, but in my opinion, that is sadly still too slow. These are the 12 vaccines that are currently actually in use. I'm not talking about a trial stage, actually available in some country or the other. Look at the flags and you will see that America has the most developed in that country, 4. China has also got 4 local indigenous vaccines. India has 1 locally developed. The UK has 1, for example. And you can see that they work across a range of different platforms. Some are messenger RNA, some are adenovirus, some are protein, some are inactivated, so a range of different platforms, and they're in use, actual use in many different countries already as we speak. And on the 5th of February, the world crossed this symbolic milestone because the number of COVID vaccinations carried out globally surpassed the total confirmed cases to date. So that in itself is great progress, isn't it? And this is a world map of vaccines, which is again very current from just a few days ago. And the darker the country, darker the shade of green, you can see the more vaccine has been deployed in that country. And as you'd expect, America, parts of Europe, the UK are well vaccinated, and other areas are beginning to step up their vaccine campaigns. But if you hone in on India, and this is again data as of the 3rd, 2 days ago, 68 million doses have been given. You might say that's great progress, but bear in mind that's just covering 2.5% of the population of this country currently. So long, long way to go. And if you track vaccinations by continent, and the New York Times did this in March, you can see again, it's sadly the divide between the developed world, North America, Europe, and the developing world struggling to catch up. And you can actually track on fascinating apps, vaccinations for each country, every country in the world, in fact. I'll just put up 4. Israel vaccinated 60% of its population. As you must be aware, theirs is a remarkable success story because they tied up primarily with Pfizer at the very start or before the start almost of the pandemic. The UK has vaccinated almost 50% of its population, which again is quite remarkable. 4 times more, 5 times more than other EU countries. And just this fact will explain why the UK has turned the corner, it would seem, while Germany and France are in a dreadful state at present. Colleagues I've spoken to just a few days ago in Germany tell me that hospitals and ICUs are completely overwhelmed by COVID. India, I told you, 2.5% of our population, so lagging way, way behind some of these countries. Which brings up the concept of so-called immunity passports. I'm not sure I agree with them. It stirs up a number of moral issues. In fact, it's an ethical minefield, isn't it? Because Israel has said, for example, that only those who produce evidence of this kind of visa or passport will be allowed in cafes, malls, hotels, gyms, conferences, etc. What about those countries and those people who sadly don't have access to vaccinations? And the real world impact of the vaccine is also apparent. Look at this from Israel, for example. And it showed that within 7 days of the first vaccine dose, the number of COVID-19 hospitalizations came down dramatically in this country. And the number of lab-confirmed infections started to come down within about 15 days of the first dose of the vaccine. That is the time at which antibodies just start to get developed. But you can see the impact it has at a country level. The same in the UK and Scotland, for example. The Pfizer jab cut the risk of admission, a Scottish study showed, by almost 85 and 95% for Pfizer and AstraZeneca vaccines, which is again remarkable. And this was after just the first dose. So that about half of people in the UK now actually have antibodies against coronavirus. Between the number who've actually been infected over the last year and the number who've received the vaccine, this country is slowly coming close to achieving herd immunity, though they still have a way to go as well. Prompting a British general practitioner to say, the vaccine is pure liquid hope. And the British are not prone to hyperbole, as you know. And this is a nice publication, recent publication from the CDC journal, which showed again in graphic form how the number of patients requiring mechanical ventilation in Israel after the second vaccine dramatically came down. And this is what our hard-pressed ICUs and hospitals need, rolling out the vaccine to enough people so we can see this kind of reduction in hospitalization, in mechanical ventilation, in ICU requirement, and in death. But then why the slow rollout? Vaccine availability, vaccine hesitancy, and lots of doctor colleagues are guilty of that as well, as you would know. A fear about side effects. And again, sometimes doctors make the biggest hypochondriacs, as we all know. My wife accuses me of being one all the time. Anti-vaccine sentiments and inequity, sadly. So vaccine availability, let's look at that. Astra, Pfizer, and Moderna, the three big ones, estimate a total production capacity of 5 billion or so by the end of 2021. This would cover no more than 2.6 billion people by the end of the year. You can now understand why any new vaccine which steps up to the plate is most welcome. The more, the happier. Now, of that 5.3 billion total, the EU and 5 other rich countries have already pre-ordered 50% of this, including options written into their contracts to order more if required. But sadly, people in low-income countries will have to wait sometimes until 2024 to receive their vaccines. And it is clearly hoped that countries with surplus needs will donate to those in need. But sadly, in a pandemic, there are very few countries who are altruistic. And look at, for example, the arrangements that Canada and US have in place, for example, with 1, 2, 3, 4, 5 multiple vaccine manufacturers to supply them with, to guarantee a supply of vaccines with them. Canada has pre-ordered 9 doses of COVID-19 vaccine per person. India, leveraging its access to the Serum Institute of India and Oxford's connection there, and really India is the world's largest vaccine maker generally, accounting for 60 to 70% of the world's vaccine output, has secured more than 2 billion doses of the AstraZeneca vaccine. But sadly, inequity remains. Immunization, as you can imagine, has yet to begin in many sub-Saharan countries and may not happen for years. When I last checked a few days ago, 130 countries, totaling 2.5 billion people, have yet to receive a single shot. I know doctor colleagues in Africa, unprotected healthcare workers who have died of COVID because they have not yet been vaccinated. And surely they should be first priority across the globe. And then there is uneven vaccine distribution, which is exacerbating the pre-existing healthcare inequalities. So in my opinion, closing this gap is not just a moral imperative, but would hasten a worldwide economic recovery. As a Nigerian GP said very pithily, the rich live, the poor die, matter of cash, really sad. And then there are reports of fake corona vaccines circulating, beautifully crafted, circulating on the dark internet, completely fake saline-containing ampules, so cleverly packaged. Let's look at the case of India. Vaccine hesitancy plaguing a country like India with an adequate supply. That is the tragedy. India's vaccine rollout has been criticized because it is indeed stumbling, and this is an article in Time magazine. And 2 months into its vaccine campaign, India is still struggling to get even its healthcare workers to turn up for their doses. Of the stated goal of inoculating 300 million people by August, that was our goal, only 8.4 million people received their vaccine, a big shortfall. That's a quarter of the number needed to stay on pace to reach that goal of August. At its current pace of 400,000 inoculations a day, I know it's climbing, it would take 4 years for us to reach this target. There are a number of possible reasons. Waning COVID-19 cases nationwide was an issue and was possibly the reason for complacency till the current second surge, I think, has shaken everyone out of their complacency. But at the time the vaccine started to be rolled out, the number of cases, you will agree, were in decline. And many colleagues, doctors included, said, what's the point? The numbers are getting less. There's no rush for me to vaccinate myself. There was a reduced perception of threat. Had the same vaccines been available during the peak of the pandemic in September last year, for example, when COVID was a word that terrified everyone, I think the uptake would have been different. There's a fear of vaccine side effects, and that's an important topic I will touch upon. There have been questions asked about vaccine efficacy, which we will discuss again. There was the hasty fast tracking of the indigenous Covaxin vaccine. I'm not saying it's a bad vaccine for 1 minute, but it was fast tracked before phase 3 data was even out in the public domain, which was a hasty decision. And then there are practical issues, huge populations, lots in villages, some illiterate, not able to access an app which often malfunctions anyway. How do they book their appointments? All these are practical issues. And look, there is more than a healthy dose of vaccine skepticism, or I should say unhealthy vaccine skepticism across the globe. This was the question asked, would you get a COVID-19 vaccine shot if and when it becomes available? This was in January. And you can see that as many as 40% of French respondents flatly declared they wouldn't. And France traditionally has a tradition of great skepticism against the medical community, against vaccines in general. So do parts of Europe like Germany and the US. India fares much better in that regard. And the UK is doing best because most people said yes, 80% in fact said yes, they would be happy to take a vaccine shot as and when it became available. And this is another wonderful calculator called time to herd, which I would urge all of you to look at. And it tells you the time it takes at current vaccine rates for a country to reach herd immunity, i.e. 70% of the population getting vaccinated. And at the current rate of rollout, America, which started dismally under a new precedent, is doing much better. And they say in 109 days, at the current rate of rollout, America will reach herd immunity. Let's type in India, and this is done on the 3rd, 2 days ago I did this. And we are 1,081 days until 70% of our population is vaccinated. That is what, well over 3 years at the present rate, which you will agree again is an unacceptable period of time when availability of vaccine is not an issue. And then, of course, there is death by WhatsApp, anti-vaccine conspiracy theories, the specter of the unstoppable rise of health disinformation and misinformation, which has haunted us, especially in this country, where we embrace WhatsApp so avidly. More than a quarter of people in the UK and the US still subscribe to at least one conspiratorial COVID belief. Bill Gates has caused COVID. The 5G network spread COVID. Rubbish like that, which continues to flourish under the auspices of WhatsApp. And this was an interesting study where Nature asked scientists to pick their biggest factors that would drive the SARS-CoV-2 circulation in people if it became endemic. And you can see 45% of these top scientists and 37% said uneven vaccine distribution and vaccine hesitancy would drive the pandemic. And indeed, the ultimate impact of COVID-19 vaccines, I would maintain, in a population will depend on this fact, the prevalence of vaccine hesitancy, not on whether a vaccine has 95% or 80% or 70% efficacy, as we love to debate amongst ourselves. Please bear that in mind. And this is sad. Superstition, of course. Tanzania shuns vaccines and turns to God. The health minister said we have no reason for vaccines, no plans to receive them. And the president said COVID-19 vaccines are dangerous, unnecessary. God will protect this nation from the disease. And sadly, the president died of COVID about a month after making this statement. So no one is immune to this. Now let's get into the science. The Indian vaccines. There is the Astra Oxford vaccine called Covishield. It is a non-replicating viral vector vaccine. A chimp adenovirus modified is Oxford 1 vaccine. There is the Bharat Serum manufactured Covaxin. That's a whole viron inactivated vaccine. Viruses can be inactivated, by heat or formaldehyde. And in the pipeline already are a number of local indigenous ones and some of the foreign ones like the Sputnik and the Novavax, which we are in collaboration to manufacture. So we are doing so much better than many countries in the developing world. I would say as good as many in the developed world in terms of vaccines and vaccine options that will be available. Now, let's look at the two big ones, the Covishield or the Astra Oxford vaccine. Let me begin by saying that this vaccine is very effective, in my opinion, and very safe, in my opinion. Let me remind you that tens of millions of doses have been administered across hundreds of countries globally. It is very cheap. It is not fragile. It does not require the ultra cold chain storage requirements that some of the mRNA vaccines need. This vaccine can be scaled up. It can be mass produced, making it the vaccine for the developing world. So then it is really a shame and sad that this vaccine has been plagued and beset by multiple setbacks. And I think Astra and Oxford University have been less than transparent with some of the data, as I will honestly discuss with you. But bear the initial words I said in mind. I do think it is an extremely effective and safe vaccine. The overall efficacy in the initial study, this, by the way, was a study in November published in December from Brazil, South Africa, and the UK. The overall efficacy in this study of 23,000 participants was 70%. But this study was criticized because only 6% were more than 65 years of age, just the age category who most need the vaccine because they're most vulnerable to COVID. And they found this curious fact that efficacy was better in those who had a longer dosing interval of 12 weeks versus 4 weeks, something which I will discuss again at some length a little later. Sorry. And then a few days ago, we had the final US data of another 32,000 participants. This was a much more robust study. Again, 76% efficacy against symptomatic COVID, 85% efficacy in adults over 65. There were lots more than 65 in this study. 100% efficacy against severe COVID or need for hospitalization. And note here that the dosing interval was a flat 4 weeks in all participants. And then we finally had the data from Bharat Serum, the Covaxin, and it was great to see this in a prestigious journal like The Lancet. Bear in mind, however, that this was a much smaller study. We're talking of several hundred as opposed to several thousand participants, ages 12 to 65 years here, and efficacy was a promising 81%. And I've just put up some differences between the two vaccines, which you don't need to look at. And I get tired of answering the huge pile of emails waiting for me every morning, sadly, as I reach my Hinduja consulting rooms. And I've put together the 12 most commonly asked vaccine questions I'm asked, and I've put them up here. And I will try and answer each of these briefly. Which vaccine should I take? Sadly, must head that list. Are they safe? Who should not be vaccinated? Any contraindications? Will they work against variants? What is the ideal duration between doses? Can I take more than 2 doses? Can different vaccines be combined? Yes, I'm asked all kinds of questions. Are they safe in pregnancy, in kids? When should I be vaccinated if I have had COVID, like so many of us already have? How many doses do I need if I have had COVID in the past? What is my chance of getting COVID if I have been vaccinated? And will I need a booster? I'm hoping that between these 12 most frequently asked vaccine questions, Anil, we've got nothing left to discuss in the Q&A section. So which vaccine should I take is my most commonly asked question. And this is always my answer: any vaccine you can access. Take the first vaccine you can access instead of shopping around. Some of us rich Indians especially have this tendency to say, I want the best. I'm going to wait. Shall I wait for Moderna? Shall I wait for Pfizer? That is crazy. Take the first vaccine you can access. It's important to vaccinate people with whatever vaccine is available rather than this vaccine shopping, as I put it, if at this stage our aim is to achieve herd immunity, which it must be. Is one vaccine superior to the other? What do vaccine efficacy numbers actually mean? Well, it's hard to say, because when you say 60% in one study and 80% in another and 95% in another, remember that these are not head-to-head comparisons. That each vaccine was tested at different times in the pandemic, in different populations, and the study was conducted at times when there were different numbers of variants floating around that particular vaccine population. So these are the results of every possible vaccine trial. And you can see that there are big confidence intervals. That's the 2 black dots, and the green is the mean, as you can see. And yes, of course, the Pfizer and the Moderna were close to 100%, 90 and 95% here. And the Astra was, for example, 70% here. But look, these trials were not conducted when there were widespread B.1, 0.351 variants circulating. These trials were all conducted when there were the existence of the variants. What I'm trying to say is, do not compare one to the other. There is no head-to-head comparison. And the WHO Expert Vaccine Committee makes a strong case for having placebo-controlled trials of COVID-19 vaccine. And I like this quote from our Soumya Swaminathan, who said, RCTs are the bedrock of modern clinical decision-making for everything, and vaccine trials should not be exempt. But I think, sadly, that is a pipe dream. You will never have the Moderna vaccine, compared to the Pfizer or compared to the Astra. We will just have to see how these roll out in the messy real-world situation, which is what we're seeing just now. But one thing I can tell you, that they're all effective in one crucial category: hospitalization and death prevention. Look, you want your vaccine to keep you out of hospital. You want your vaccine to keep you out of the morgue. And all these 4, for example, are 100% effective in doing that. Current data suggests. The next question is it safe? There is so much vaccine hesitancy, even in doctors. I would say so far they're remarkably safe. There are no major safety signals, though there are many red flags, some false alarms, some red flags that we need to be alert to. But remember that because millions of people are rapidly being vaccinated, vaccines will inevitably seem to be temporarily associated with some rare adverse effects. It's bound to happen. 1% of millions and millions is a large number of people. Therefore, continued careful monitoring is certainly required. And these are the questions I'm asked all the time. Is it safe with G6PD, with anticoagulation, with I've got food and drug allergies, I'm on steroids, I've got blood pressure and diabetes, I've got cancer, I'm immunosuppressed by steroids. I'm on blood thinners. Yes, yes, yes is the three-word answer. And what about immunosuppression? One category which is of great importance, really. There is a study called the OCTAVE study, which is enrolling 5,000 immunosuppressed people to test just this. This study will help us understand how effective the vaccine is in immunosuppressed patients. The population with cancer, with inflammatory arthritis and bowel disease, kidney and liver disease, transplants. Remember that these vaccines will provide a lower level of protection if you're immunosuppressed. It doesn't mean you should not take it. Of course, it's very important that you do take the vaccine, but what kind of protection you have is unclear. Possibly it will be a lower level. This study will answer just that question, and it is halfway complete. Are there any contraindications to the vaccine? Who should not be vaccinated? There are just three, in my opinion. Obviously, if you have an intercurrent acute illness, you would not suggest the patient vaccinated till he recovers from that illness, whatever it is. During active COVID, no one would recommend vaccination. And if you are hypersensitive to any of the components known to be in the vaccine, then you should not get yourself vaccinated. Apart from these three, there is none that the CDC recommends, and there is no excuse really, therefore, to not be vaccinating yourself. Yes, allergic reactions to the vaccine are reported, starting with this initial report in JAMA. They occur at a frequency of about 2.1%. They're more common with Moderna than Pfizer, but there were only 16 cases of anaphylaxis, and only one of these reactions needed ICU. Anaphylactic reactions to the second dose did not occur, or did not mean, if you got a reaction, to your first dose, it should still not preclude the important second dose, which boosts your immunity. And bear in mind that many of these reactions are allergies or hypersensitivities to PEG, polyethylene glycol, which is one of the constituents of many vaccines. Nice article from the New England Journal of Medicine showing that even patients who had these delayed cutaneous reactions after, say, dose 1 did receive dose 2 and got milder reactions, for example. This patient received dose 1, got this reaction, and had no recurrence for dose 2. So there is really very little reason to be scared of taking your second dose of vaccine. But then there are more worrying reports of an ITP-like illness post-Moderna or post-vaccine, a rare clotting disorder, which again clouded hopes for the Astra vaccine. This is very much like the HIT syndrome we see in patients who receive heparin. We'll come to that a little later. There are reports of glands developing in 1 in 6 people who receive vaccines. And there is advice that the mammograms that you do should be delayed by 4 to 6 weeks post-vaccine, because they may cause confusion and may actually mimic breast cancers when the patient just has a vaccine reaction. So local skin reaction, cutaneous reactions, axillary glands are not uncommon, and they mean little. But then this was the real spanner in the work when blood clot fears tended to derail the Oxford vaccine rollout. Sorry. Can you see that, my screen? Anil, you can see my screen?
Yes, sir. Yes, sir.
And you can see how prudent countries in the West are. And 20 countries, 20 European Union countries, and you can see them in red here, chose as a result of this signal that came through to suspend the Astra vaccine rollout. Let's go with those clotting figures. 20 countries pause vaccination because rare clotting issues, sometimes accompanied with low platelets, again, you can see that in HIT syndrome, isn't it? Were tending to be reported from across the globe, especially in Europe and Northern European countries. So cases of mesenteric vein thrombosis, cerebral venous thrombosis especially, pulmonary embolism, very much like the HIT syndrome, as I've said. But these were rare. You add them up and there were 37 cases in around 20 million. They tended to occur more in younger women under 55 or 60. They tended to occur within 14 days of the vaccine. So there was a temporary halting to vaccination in 20 countries, which I think was not very wise because, again, COVID resurged there. We do recommend that patients report bruising and bleeding and severe headaches, which can be a marker of cerebral venous thrombosis. So give that advice to your patients post-vaccine and don't ignore any symptoms that they complain of. Though the commonest, of course, is just a day or two of fever and general malaise and headache. And the WHO was strongly against this suspension, even temporary, and recommended its continued use, stressing that the benefits far outweighed the risks, which all of us would agree. And the European Medical Association, the Drug Association there, finally, after deliberation, said on the 18th of March, it is safe to use, but put a package insert warning about possible side effects like the ones I mentioned. And this study is out in Lancet 2 days ago, and this was, I think, should put this controversy to rest. This was very detailed number crunching from the Danish National Patient Registry, and Denmark reported the most incidence of cases here. And they compared them with the population in general for different age categories. And the final conclusion was we report that the number of venous thromboembolism in relation to the Oxford COVID-19 vaccine does not seem to be more than the expected incidence rate in Denmark. And there were detailed statistics to back that claim, which I will not labor the point with. So you can tell your patients it's safe. It probably occurs, these side effects occur at the same incidence as they would in the general population. Look, just because something happens after vaccination, it doesn't mean that it's caused by the vaccination. At the same time, do not ignore these side effects is my suggestion. Careful monitoring must continue. The present incidence is less than 2 per million, 1.5 per million. You can tell your patients, and then they can make a call themselves. But I know I would not suggest delaying vaccine rollout because of these clotting fears. And look how vaccinations paused once this red signal was raised, and then slowly has resumed and has still not reached its level. And you can see how these three very countries, France, Germany, and Italy, possibly because of this vaccine pausing, are now reporting great numbers of cases. So it's a balance between the theoretical side effects, I would say, of the vaccine, those which cannot be ignored. I'm not suggesting you brush them under the carpet, with the very real risk of relentless escalation of this pandemic. And it was a shame for the world's most important vaccine, the most widely deployed, the cheapest and easiest to store and administer. And as Eric Topol, who is on the FDA of the US, said, the world, the species depends on this vaccine. He was referring to the Astra vaccine. This is 2.5 billion people's worth of vaccine. Now, we come to the next most important part of my talk, which is, will the virus work against variants? And I've tried to make this complicated topic as simple as possible for you. Let's classify variants, or as some people call them, scariants. SARS-CoV-2 variants have been classified by the CDC as variants of interest, variants of concern, and variants of high consequence. And there are three variants that have rapidly become dominant in their countries. They have been classified as variants of concern, not yet called variants of high consequence. So that is the terminology. Don't call them mutants, call them variants, and follow the terminology which says these are three variants of concern. There is a UK variant, a South African variant, and a Brazil variant. This is what they are known as, depending on the country where they were first discovered. And why are they important? Because there is evidence that variants are more transmissible, they cause more severe disease, they may be less vaccine responsive. Variants, when they infect someone, result in higher viral loads. These patients become infected and stay infected for longer periods of time, and they can certainly accelerate the pandemic. And in fact, in my opinion, the UK variant is probably the main reason for the current second surge that we are seeing through parts of this country. But I like this in the Times of India by Dr. Arvind Singh Soin, who said our deviation from COVID appropriate behavior is currently the biggest variant of concern. And that is sadly what has happened. People, after taking their first dose or sometimes even before, have stopped masking. And every public health study has shown that more important than vaccines is to continue your masking. So this is probably, as he puts it, the greatest variant of concern. So this is the SARS-CoV-2 virus, and this is the UK variant. And you can see here that it differs because of a number of mutations marked in red. And this frightening electron microscopy picture is the spike protein, is an EM picture of the spike protein. And these three mutations are the ones that are responsible for the B.1.17 UK variant. And are the three key mutations. And this is a study which showed that the risk of mortality when you are infected with a variant is a concern. There was an increased hazard ratio of 1.32 to 2.04, which translates to a 64% increased risk of death. And these are your Kaplan-Meier curves showing that your survival probability is lower when you have a mutant than when you have the original strain. So they need to be treated with the greatest respect. Now, sadly, genotyping in this country is in its infancy. That's really a shame. In a country like New Zealand, every single case has genotyping done for it. Here, we must not have done more than a few thousand, I would say, if at all that. And you can see the more you look, the more mutants and variants you will find. And this is some recent Indian data. And you can see the UK variant in the 736 cases we tested is starting to rear its ugly head. And there are South African variants and even a case of Brazil variants, which in the end will spread and become dominant strains. And there was this new Indian double mutant, a variant of interest again, which had a combination of two gene mutations, which can escape antibody neutralization and which is associated with increased infectivity. So this is going to be our major hurdle as we progress in this second phase of the pandemic. But at the same time, I'm going to be optimistic and say that we shouldn't be too worried about variants. Why is that? Because mutation is what RNA viruses do. Because the mutation rates of SARS-CoV-2 are still much less than of, say, influenza. Because neutralizing antibody titers post-vaccine are still reassuring, even in the presence of variants. And remember, we are so obsessed with the figure of antibody titer, and I see some people parade it as a badge of pride and honor. Oh, my level is 160 and my level is 10. It makes not an iota of difference. We don't know what level is protective, first of all. We don't know how long that protection will stay. And there is no evidence that having antibody titers of 150 are more protective than 4, for example. Crucially, those are B-cell responses, and we have no idea, no inkling on the effect vaccines will have on T-cell responses. Look, I would argue that even if you have no antibodies, your T-cells are primed and ready, and when you do have a second infection, it will be much milder than your first, and you will get some considerable level of protection. And all vaccine trials on all variants have shown one thing, again, that they eradicate severe disease. Finally, our vaccines themselves can be tweaked to keep up with these variants. So I've put up here 6 or 7 reasons why you should not be too alarmed about variants, but they are still something to be extremely concerned about. And this is a very important side, because this is from a South African group which looked at vaccine efficacy against variants. And yes, vaccines of these are all the different vaccines, the Johnson, the Pfizer, the Moderna, the Astra, Novavax, varying efficacy in the face of variants. As you can see, figures of just 50%, for example, in the face of Brazilian variants with the Sinovac vaccine. But this is the heartening column, that the efficacy in preventing severe disease remains close to 90 to 100%. And that is what is pivotal. So the news that our vaccine, the AstraZeneca vaccine, works against two variants was hugely satisfying. It has been shown to be effective and maintain its effect against the UK variant and also against the Brazil variant. But sadly, you can see it is not effective, poor efficacy against the South African variant if you measure that efficacy vis-a-vis neutralizing antibodies. And you can see how nicely here antibodies rise and are high with the normal original strain, and you get antibodies but at much lower levels in the face of variants. So it's not that you don't get antibodies, you get lower antibodies, but we have not yet understood the significance of that. So what do we need to combat mutants going forward? Scientists are developing boosters and booster vaccines to tackle variants. Next generation vaccines will clearly look into tackling these variants as well. And yes, most of us feel that new vaccines will be needed globally, almost like an influenza shot, to combat this. So what we do need, I can tell you, is to vaccinate as many people as we can, as fast as we can, with the existing vaccines we have. We can fast track next generation vaccines, and already developers are working along these fronts. You can tweak existing vaccines, and the messenger RNA vaccines are very easy to tweak, but these vaccines are very hard to scale up. A messenger RNA vaccine needs about 30 different biological components, so it's difficult to access them, but they can be tweaked very rapidly. The Oxford vaccine is the opposite. It can be scaled up on a huge scale, but because it's not mRNA technology, it is that much more difficult to tweak. But GSK, a Californian company, France, are already developing what they call next generation vaccines, which would generate immune responses across all strains, which would be directed not just at spike protein, as all the current vaccines are, but against multiple epitopes, including the crucial T-cell response I talked about earlier. And as Tony Fauci said, we need to get as many people vaccinated with the current vaccine that we have as we possibly can, and prepare for the potential eventuality that we will have to update this vaccine sometime in the future. Okay, let's move on. What is the ideal duration between doses? Oh God, I'm tired of this question. Please stop asking me this. But let's look at the literature and then you make up your own minds. So a sub-analysis of the initial Astra-Oxford vaccine from the initial study I alluded to showed the vaccine efficacy was 81% if the booster was given at 12 weeks and 55% if given at 4 weeks. This was a huge hiccup for Astra. This was a subset actually who received the low dose standard dose regime when the two doses were considered by accident. And this group certainly did better in terms of immune responses. It eventually emerged that this improved response was not because of low dose and high dose as was first thought, but because this group also had a longer period between the two vaccines. Now remember that these patients were a small minority, the ones who received it at 12 weeks. Remember also that this was not a head-to-head comparison. This was serendipity. This was chance. This was sub-analysis done later. So again, I think we will have to wait and watch. The honest answer is we don't know what the correct time interval is. All the trials have been designed for 4 weeks, not 6 or 8 or 12. It was not a head-to-head comparison. And don't forget that the just published US data showed that the efficacy was 80% with all boosters, and all boosters were given at 4 weeks here. So you have to choose which data you find more convincing. You've got lots of different recommendations. The WHO says 8 to 12 weeks. The CDC says a delay of 6 weeks is acceptable. The ICMR says 4 to 8 weeks. The UK said a 12-week gap, but that is essentially so more can receive the first dose. Let's look at this slide, which summarizes the pros and cons of early versus late, and then you need to make up your own minds. What are the advantages of early without a delay? Look, immunity can wane between the first and a very delayed second dose. Patients may forget to come for their second dose if that time period is 3 months, for example. Your behavior gets complacent after one dose. That's human nature. I stopped wearing full PPEs and just wore an N95 when I was in a hurry after I received my vaccines. Breakthrough cases of infection between doses can occur, and this greatly erodes vaccine confidence. That's what we're seeing now, isn't it? Large numbers of cases and people asking, is the vaccine working? If it is, why are so many people filling up hospital beds? And are there any advantages about delaying the vaccine? Yes, this delay, and this is based on strong immune principles, that a delay elicits a slightly stronger antibody response. And when your vaccine capacity is limited, and we don't have that problem in our country, as far as I can tell at present, you can have greater epidemiological impact and have greater epidemiological good and protect more people if you delay the dose and spread it out, so to speak. But with the emergence of variants, it is even more imperative to vaccinate across with at least one dose. So no data on how long a delay is safe without compromising efficacy. And my current recommendation, if it was me just now at this stage in the pandemic, when it's accelerating alarmingly, is that don't be greedy to say, oh, my immune responses will be a bit better at 6 weeks or 8 weeks. Take your second dose at 4 weeks. Because remember, to be protected, it takes 2 weeks after your second dose. Do not let your guard down before that. Then, should you take more than 2 doses? Again, Indians are, I don't know if it's greed or is it, people in the developing world, most parts would be wondering how people can ask that question, can I take more than 2 doses? Do not take more than 2 doses at present is the answer. All these vaccines have been designed as 1 or 2 dose immunizations. It's unclear how much additional benefit you'll get if you take 3 or 4 doses. They, in fact, may have incremental risk. The answer is we don't know. But you have someone famous on your side because Anthony Fauci proposed a few weeks ago a 3rd dose in 6 or 12 months may top up antibodies. And he said this might be more practical than a new vaccine. But this was just a hypothesis. It's untested. And clearly we don't know. So the current recommendation is please do not take more than 2 doses, whatever your antibody levels are. And then again, we love to mix and match, don't we? So can I combine 1 dose of the Pfizer vaccine with 1 dose of the Oxford vaccine? No, not at present, though Astra is launching a combination of different drugs in Azerbaijan and the UAE, just because they need to be widely rolled out in large numbers. And then a very important issue, are these vaccines safe in pregnancy? And remember that there are more than 75,000 infections and 85 deaths in pregnant ladies in the US alone because of COVID. And pregnant ladies we thought were generally okay, but we now know that they do have a higher risk of hospitalization, of ICU, and of dying when they have COVID. And there were no trials to date in this population till a week ago, this important study in the American Journal of Obstetrics and Gynecology, the first study using both the mRNA vaccines in just 84 pregnant women, very important study, which showed that vaccines induced robust immunity and that there's immune transfer to neonates and they are safe and they are recommended. And I hope that we will roll out these vaccines to pregnant ladies. I would be recommending that we do this soon, protection for mother and infant. This is even more important than pregnancy. Are they safe for children? There's no reason why they should not be, but there has been no data because they've been excluded from trials. They've been considered a low priority group, but they are an extremely important reservoir of infection. And don't forget that kids under the age of 15 account for 1/4 of the globe's population. And certainly vaccinating children would speed up our target of reaching herd immunity that much faster. It would allow schools, it would allow colleges to more safely open up. And don't underestimate the huge toll that this 1 year of lockdown and no school and remote schooling has taken on kids across all ages, whether it's school or college. There are experts who feel that this will be a permanent mark on their development, which they will never be able to catch up with. Indeed, Israel has vaccinated now all children up to the age of 16. And their next rollout group, and imagine the luxury of being able to do this, is now the 13 to 16-year-old. And there are trials in pediatric populations as young as 3 years, you'll be happy to know, underway. And again, Pfizer has just announced on March 31st, so that's 4 days ago, and this is pre-journal release, that their vaccine in 12 to 15-year-olds in the US, this was a pivotal study, had 100% efficacy, no adverse safety signals, and very robust antibody responses. It was thought that kids would not mount such a good antibody response, but they had excellent responses. So I hope that we are not far away from rolling out these vaccines to younger and younger populations. In my mind, it is safe, and that is the only way to get this pandemic to a halt. And look, there are studies underway with Moderna testing 6 months old to 11-year-olds. So the true pediatric population is also going to be included in subsequent studies. Should vaccines be given to you if you have recovered from COVID? And when? Yes, they should, because how long your natural immunity lasts is unclear. And you all know that reinfection is rare, but is not impossible. In fact, an ICMR study has shown worryingly that there's a 5% rate of reinfection if you've had COVID once, which is quite a frighteningly high figure because the rest of the world reported this as 1%. And as your immunity wanes, you will then become susceptible to reinfection, or perhaps reinfection with a mutant strain, which you don't have antibodies to. But the recommendation is that you need to delay your vaccine for 90 days after you've had COVID. So tell your patients to be patient, that they have antibodies that will certainly cover them for at least 3 months. And this was a very interesting study from the Lancet, which looked at 4 million people in Denmark. And they showed that vaccination of previously infected people should be done because natural protection cannot be relied on. And how many doses do you give such people in a post-COVID patient? This was a lovely abstract from out of CROI, which is the world's premier HIV conference, which is hijacked this time by COVID, another virus, where they showed that 1 dose of a vaccine may be all that you need to give someone who's already had a past infection. Because your antibody titers after 1 dose, if you had a previous COVID infection, your antibody titers were higher than in people who were naive and had had even 2 doses. And perhaps changing this policy would prevent these patients from having the unnecessary pain of a second vaccine and freeing up the vaccine doses for others. But at present, we still have to say that while 1 dose may be enough in terms of antibodies, 2 are still the current recommendation. So don't keep checking antibodies obsessively. Past infection or not, I would still say that currently you should be taking 2 doses of the vaccine. Next important question, what is the chance of my getting COVID after vaccination? Now, this is a very important topic. No vaccine offers 100% protection. A vaccine is not bulletproof. It's much harder for vaccinated people to get infected, but don't think for 1 second that they cannot get infected, are the words of Paul Dupré, the director of the Center for Vaccine Research. And that should really make you pause and reflect. But what each vaccine does offer is what I told you it has been shown to do in almost all studies, near 100% protection from the big 3, severe infection, need for ICU, and mortality. And this is some back of the envelope calculation of the 75 admissions currently under us at the Parsi General Hospital. My registrar Varun was kind enough to tell me yesterday that 25% of the 75 we currently have in under us are those who have already received their first dose of vaccine. But it's mostly within a week or 2 of having received that dose. And this was a very interesting study of healthcare workers in California, that means you and me, and how frequently they got SARS-CoV-2 infection after vaccine. A wonderful study from California. What did they find and what did they do? they had 36,000 healthcare workers who had received the mRNA vaccine. And because it was hospital policy, these healthcare workers continued to have every single week a PCR test post-vaccine. It was part of the hospital policy. If they were positive, they could not work. And 379 of these 36,000 tested positive post-vaccine for the virus, which gives you a risk which is low of 1% post-vaccine, but not zero. And the majority who tested positive did so within 1 week of the first dose. As the days post-vaccine increase, your risk of getting SARS-CoV-2 exponentially decreases. But look, there were still 7 doctors who tested positive 2 weeks after the second dose. So the vaccine does not prevent you from getting infection, though it is generally milder. And this paper should underscore the critical importance of continuing public health measures. And this is the chart from the table. 379 out of 36,000 vaccine recipients did get infections, but as the number of days post one vaccine and dose second vaccine goes on, you can see how the numbers exponentially decrease till it's only 7 out of 36,000 who still get an infection even 15 days after. So vaccination, not 100% protection. And this is data from a UK study which showed that 4% of all hospitalized patients had been vaccinated. Again, most early after the first dose, the median time 5 days from the first dose, but again the same message, do not drop your guard post-vaccine. And it's one theory that infection may be acquired at crowded vaccine clinic visits. Because look, it seems to occur 5 days after your first dose. And if you come and visit some of our hospitals, you will see that vaccine clinics are extremely crowded these days. And maybe you actually are exposed to other people, pick up your infection there, actually get the COVID, and then some people blame the vaccine for this. Now, do I need to take a booster? And how often will that be? My answer is probably we will all need boosters. It may be like you need a booster for influenza, or you need a booster even for something like tetanus. How frequently is the million-dollar question? I told you the SARS-CoV-2 virus mutates less frequently than influenza. So my guess is perhaps not annually, hopefully not annually, perhaps every few years. Or perhaps think of the yellow fever vaccine, where before you travel to a hot spot, like say South Africa or say Brazil, where you know there are variants, you might need a booster to specifically cover the variants which you might be exposed to there. So like it or not, I think vaccine passports and visas are here to stay. And let me end by reminding you again of this tale of vaccine inequality. Consider yourselves fortunate. Most of you are doctors listening in and have received 2 doses of the vaccine or should have. And any lay people will have certainly received 1 dose. But look how disproportionate that is in terms of income when you break it down into high income and low income countries. And as the head of WHO reminded us, a me-first approach to vaccination will never defeat this pandemic. Global cooperation is needed. And we have this wonderful organization called COVAX. We have Gavi, we have CEPI, which are in charge of this Herculean task of fairly distributing the vaccine to countries which do not have the resources, do not have the contacts, the contracts to acquire the vaccine on their own. And that is most of the globe. And this was really a heartwarming story when on the 20th of February, a cargo plane arrived in Ghana. It carried 500,000 doses of the AstraZeneca vaccine, which had been developed in Britain, manufactured in India, with needles from Dubai, an international initiative backed by 165 countries, and the lives that it would save were all Ghanaian for the country of Ghana, which would never have been able to afford these vaccines without this initiative by Gavi. So what it will take to vaccinate the world against COVID-19, 11 billion doses will be needed to vaccinate 70% of the world's population, assuming 2 doses per person if you want to reach herd immunity globally. And we are years and years away from that happening. And therefore, this pandemic is with us, sadly, for years and years. And therefore, what's needed is companies working together to boost vaccine production, sharing technology. Do you see that happening? I'm being cynical, but I don't see that happening, sadly, like Astra and Pfizer working together, rivals as they are. And this is perhaps something that we can push for. Intellectual property rights for vaccines need to be waived. And India and South Africa are campaigning for this at the WTO. This is a catastrophic pandemic. And if not now, it is written into the fine print that in this kind of situation, you can waive intellectual property rights, which I think is what we should be doing, so more people can be making vaccine faster. I think it's a shame that countries hoard vaccine. I gave you the example of Canada and America, which now have more vaccines than they know what to do with. And they must donate their surplus via initiatives like Gavi, which I spoke about. Make vaccine access easy, even for the non-tech savvy. How are the non-computer savvy people to book their appointments on an app? Make it open, make it walk-ins, make every school, every village have vaccine centers, so we can really speed the roll-up. And India has its extensive polio vaccine experience to rapidly achieve just such a scale-up. Again, the WHO chief has said that we should waive the patents on COVID vaccine, thus putting the world on a war footing. And I think this is my last slide. This was a piece which is to be carried in next week's perspectives in the New England Journal of Medicine. And I've chosen it because there was a nice quote by these authors. The topic was vaccine nationalism to vaccine equity. And they say, and I'm going to end here, that vaccinating the world is not only a moral obligation to protect our neighbors, but it serves our own self-interest by protecting our security, our health, and our economy. These goals will not be accomplished by making the world wait for wealthy countries to be vaccinated first. Getting the world vaccinated may well be the critical test of our times. So I'm going to stop sharing, and I think we are all blessed to be where we are, to have the vaccines that we have. Let us count our blessings and let us never lose sight of our less fortunate neighbors and try and do our best to help them as well. Thank you, Anil and the others.
Thank you. Thank you very much, sir. Thank you. Fantastic. Dr. Jawahar.
I hope I've not bored everyone and put you to sleep.
No. It was great.
On the contrary.
Thank you.
Thank you, Dr. Zarir Ruwadia. Fantastic discourse on the vaccine. I think it's thrown light on so many topics that you've completely disarmed the panel which was supposed to ask you questions. I don't think they have any questions to ask you anymore, because all of them have been already answered. I think from what I gather from your talk was that when historians look back at this time frame of history, they are going to write it as a story of human endurance, ingenuity, and unfortunately human stupidity. And to this, I will quote Albert Einstein, who said that two things are infinite, the universe and human stupidity. And he said that he was only sure about the universe. So I think we will leave it at that, and we'll ask Dr. Bharat Bhatt to come forward and start the questions today. As I already said, I think you already disarmed everyone, because all the questions seem to have been answered completely. But I will ask Dr. Bharat Bhatt to start the question. Dr. Bhatt, please unmute yourself.
Yeah, I think, Zarir's nice sentence itself. So I want to prove myself that I'm awake and my question has been answered.
Okay.
So go to the next person, I think.
Okay, so I think...
Jawahar, you can request the next person.
Yeah. So there were some questions which were given earlier, and I can see that most of them have been answered. But if anyone wants finer points to be answered, I will start with Dr. Preeti Shankar to start with her questions.
Yeah, very good afternoon, Dr. Zarir. It was an excellent and very intuitive talk, lot of information. Thank you very much. I want your opinion on ladies who nowadays, late marriages are in the swing, and someone in the mid 30s or 30 to 40 age group, if they are planning conception, should they get vaccinated, wait for the 2 doses to be completed, and then plan the conception, or go ahead? Because as of now, 30s are not in the vaccination list, not in the priority list. So it may take another year for them. And that is the phase where we have, little bit of infertility factors also going through. Your opinion, please, doctor.
That's a very good question. I would say they continue as they normally would in terms of their planning of family. And if and when the vaccine is rolled out to them, I think by then data will emerge that this vaccine is safe, even if they are pregnant. And then they can hopefully take it and protect themselves and protect the fetus as well. So don't wait is my suggestion, either for the vaccine or for the timing of your family.
Thank you very much, doctor.
Thank you.
The other question is already answered by you. Which of the vaccines works against the variants? Thank you.
Dr. Bhairavi.
Good afternoon, sir. Thank you so much for a lovely session.
Thanks for inviting me.
Yeah, thanks. I wanted to ask that what are the ideal levels of INR preferred while on anticoagulants for vaccination?
Bhairavi, I mean, if your INR is over 2.5, you can maybe ask the patient to hold the anticoagulation for a day or two. Before they go ahead with their vaccine. But at the most, we're talking about a local bruise and a local hematoma. Hardly a reason not to take their vaccine. So my advice for patients on warfarin and Novax has been to hold for 2 days at the most, and then go ahead and then restart straight afterwards if there's no bruise. And that doesn't apply to Ecosprin, Clopidogrel, and even dual antiplatelets. Patients on those drugs should certainly take their vaccine and not omit their Ecosprin. I think some of the incidents of cardiac events we are seeing are in patients who stupidly hold their antiplatelets and have stent thrombosis.
Yes, sir. Thank you so much.
Thank you.
Dr. Kumar.
Hello, sir. It's been a wonderful lecture.
Thank you.
I have a question. Does prolonging the interval between 2 doses of the Oxford vaccine increase the risk of mutation in the virus?
No, I mean, for the reasons that we discussed, I don't think it's wise to prolong it too much. One argument is that you want to give as many people 1 dose as possible to reduce their chance of being infected by mutants. And the other is quickly get your immunity, take your 2nd dose at about 4 weeks. And that remains my current recommendation. The way the pandemic is accelerating now, partly driven by mutants, I would say that any of you who are still hesitating, take your vaccine at 4 weeks, at the most 6, but I would say 4. But good question.
The second question, sir, because Covaxin is acting against the inactivated virus, whereas Covishield acts against the spike protein. Will Covaxin be more effective against the mutants?
No, I don't think there's any evidence. It's not been put to the test, so we don't know. The same with cancers. Many oncologists are fond of saying one is a dead vaccine, let's use it for our cancer patients. There is no evidence that one is superior and one is safe and unsafe. So the same advice, choose any vaccine that you can get at the quickest.
Yeah, thank you very much, sir.
The only reason I hesitate to recommend the other vaccine is that we've got so much more data with the Oxford vaccine. The Covaxin vaccine has been tested in 800 people. It's being rolled out more slowly. So maybe time will give us the same incidence of side effects as we are seeing with the Covishield.
Thank you. Thank you.
Thank you.
Dr. Rajiv Shah.
Fantastic lecture. As usual.
Thank you, Rajiv.
Sir, in a person who suffered or taken the first dose, then he gets COVID in the intervening period. Now he takes the 2nd dose after how many weeks?
3 months is the recommendation, Rajiv.
3 months, 12 weeks.
3 months. He should hold on. He's got immunity from the first vaccine dose. He's got immunity from COVID. So 3 months is the recommendation of the CDC.
Thanks a lot.
We're seeing that combination commonly, isn't it?
Dr. Gwalani, please.
Yeah, good afternoon, sir. Thank you for the very enlightening talk.
Thank you.
My question is partly answered. My question was 2nd dose scenario following severe reaction of 1st dose. My friend itself had severe urticaria on the face and angioneurotic edema. So now she is hesitant whether she should take. So what are the precautions she takes so that she can take the 2nd dose? As you said, it may not occur.
I think take it in a hospital, for example, instead of a smaller center. Have an EpiPen ready so that you can inject yourself if there is a problem. But as the NEJM paper convincingly showed, it is safe in people who've had a bad local reaction to go ahead with their second dose. In fact, reactions are less, not more, after the second dose. So ask her to be cautious, of course, but the benefits will outweigh the risk, I would say. Have a line in place, and if you need to take a shot of steroid or your EpiPen.
Okay. Thank you so much, sir. Thank you.
Dr. Alpa Thakkar, please.
Good afternoon, sir. Thank you for the very comprehensive lecture. It has solved most of our doubts. My question was, after the COVID infection, if one jab is enough, but you recommended that we should better go for two. Okay. Thank you, sir. Thank you.
Thank you.
Dr. Janak Shah. Dr. Janak Shah, unmute yourself, please. Dr. Janak, unmute yourself.
Okay. So it was a very nice lecture, superb lecture. You have answered part of my question, that was, should immunosuppression, patient on immunosuppression drug take this vaccine? But you have answered yes, they can take, but do they have to modify the dose?
Very good.
Of mycophenolate or tacrograph?
Very good question. There is just one recommendation from the American Rheumatology Society, which is those who are on methotrexate should not take their dose of that week. So suppose they take methotrexate on Sunday, for example, and they get their vaccine on the Tuesday, miss that one dose of methotrexate, but other immunosuppression should continue. Of course, we're not talking about strong chemotherapy and things where you'd really be hesitant to take the vaccine because your immune status is so poor. But the traditional steroids and the MMF do not need to be modified, is what they say. Just the methotrexate 1 week each time after each dose of the vaccine, you must tell your patients.
Okay. One more thing, whether they should take Covishield or Covaxin?
No difference. No difference between the two. So one being virus inactivated and the other being dead will not make a difference.
Thank you.
Thank you.
Dr. Shaila, please.
Good afternoon, sir. It was a very lucid talk.
Thank you.
I have two queries for you. What would be the ideal period between taking a flu vaccine and a COVID vaccine?
Good. Let me do one at a time. Yeah. So I would say not in the same week. Get over the reaction of one because both can cause a sort of flu-like syndrome for a day or two. So get over the effects of one. I would say a week later maybe would be fair. There's no great rush for the flu vaccine these days. You know, the remarkable thing is we're not seeing any influenza. We're not seeing any flu. So if you want to know the way to combat flu globally, it is to wear masks because everyone has been masked up. There are literally no cases or very few cases of influenza. Yes, at the Breach Candy, for example, just a few days ago, Dr. Aruna sent me the report of someone who has both together, influenza and SARS-CoV-2. But generally, globally, we are seeing very, very few influenza cases just because it's spread airborne and no one is without masks these days. But to answer your question, about a 1 week gap, I think is fair.
And my second query was, there are a few returnees from the UAE who have taken first dose of Sinopharm, but then they've lost their jobs and they cannot go back. And if they have to cover themselves in India, after how many weeks can they take the next or Covishield, Covaxin, whatever in India?
Great question, Shaila. Really, I don't know, as I said, because it's not a common situation. And the advice generally has been not to mix and match. But I guess what I would do in this case is if they have really good antibody levels, I would just hold on. But if the antibody levels are starting to plummet or really undetectable, then I would maybe take one or the other, maybe 3 months later or 6 months later.
Thank you, sir. Thank you.
Dr. Atul, do you have any questions?
Yes, thanks, Zarir. It was a wonderful lecture, very informative as usual.
Thank you, Atul.
My only suggestion is that I think we all family doctors should be involved to give vaccines.
That's a great point.
Maybe I think that will hasten the whole process.
That is a great point, Atul. But I'll tell you what they do in the UK. In the UK, every family clinic is allowed to vaccinate outside their general working hours. So either before or after. Each general practitioner is paid £14 for a dose. So there's some incentive. I'm not saying we're doing it for the money, but they're given a small incentive of £14 for each patient vaccinated. And the patient has the choice of going to any general practitioner's surgery and taking their vaccine. I would think that that is the only way to increase the rollout from our present dismal rate of 2.5%. So I think that is the best suggestion I have received all day, and that all of you should maybe petition that you be allowed to vaccinate if you have the facilities and are willing to do it, of course. You need to meet certain requirements, but they're not major requirements. You need to have the space, because you might be overwhelmed with your normal work and your vaccination work. But I think why not put it down as something that you can propose to the government? And I would strongly endorse that.
Just for your information, I'm a president of GPA, and we have already made representation to the authority. And let's see, we are awaiting the reply.
That's a very good suggestion.
We have some questions which have come in. There's a question: in the absence of neutralizing antibodies at the end of both the shots, a month after the second shot, what should be done?
That is very rare, and really it's not a common situation. First thing is to make sure they are really neutralizing antibodies. Actually, neutralizing antibodies are checked in very few centers. We do the spike protein antibodies, which is not necessarily the same thing. As I told you, you may have no neutralizing antibodies, but your T cell responses may be primed and ready. I think it's a risk you take whether you take a third dose. You may still have no antibodies at the end of a third dose. What effect the third dose will do, whether it can cause harm, because all designs of all studies have been for 2 doses at the most, and the J&J is just 1 dose, as you know. So it's a rare situation. I don't have an answer. There is none just now. But I'm sure as we get through this pandemic, there will be more and more patients like this, and we will have the answers. But good question.
There was also one question whether this recommendation of 12 weeks was more of a matter of policy and find the data later.
I would agree with that. And as I said, that was really put to question when the US trial published a few weeks ago showed that the efficacy was excellent, with everyone getting it at 4 weeks. So we have more data for 4 weeks than this small subfraction in the original trial who, by serendipity and chance, not by design, received the vaccine much later. So I think we should follow the science. We must trust science, not the science.
Because the goal of that study was to see if the second dose delayed to 12 weeks was good enough or not.
No, it wasn't the primary goal of the study. This just happened that some patients happened to be in this category. So as I was saying, trust science, not scientists. Scientists are only human. They are subject to the same cognitive biases, the same egos as all of us. And we should go with the data.
Thank you, Dr. Odwadia. I don't think there are any further questions here. I think most of it has been answered. Thank you so much.
All of you.
Thank you. Thank you very much, sir.
Anil, I finished.
I would.
Yes, sir. Thank you. Thank you very much, sir. It was fantastic.
Thank you, sir.
Thank you. Thank you.
Lovely lecture.
Dr. Adhwaryu, please unmute yourself.
Thank you.
Dr. Adhwaryu, please unmute.
Yeah.
I would now like to invite Dr. Adhwaryu to come forward and tell us something about the BMU, which is one of the oldest physician bodies in the country, and one of the pioneering institutions. He would like to him to speak upon that, and then introduce the next speaker and the next question answer session with Dr. Tushar Shah.
Yeah. Good afternoon, everybody. Bombay Medical Union is the oldest medical association of India. One of the objectives of the Bombay Medical Union is to update the medical knowledge of its members and to dissipate the same to lay people also. With Bombay Seaward Medical Association, it has been organizing these activities together since many years. I have a proud privilege in introducing Dr. Tushar Shah. Dr. Tushar Shah, an MD physician, is practicing at an He is a passionate teacher whose innovative methods of imparting medical knowledge have made him very famous. He is amongst the most popular teachers of the family physicians. He practices what he preaches and inspires us to do the same. He has created a cadre of family physicians who practice evidence-based medicine. He has personally treated nearly 400 indoor COVID patients, 8 of whom he could not save. His team of 10 doctors has formally managed over 10,000 COVID cases on an OPD basis. Amongst his other qualities, he is a poet and a humorist, having contested in the finals of the Laughter Challenge show on Star One. His interest in teaching has enabled him to form a Telegram group, avidly followed by over 2,000 doctors, where he uploads videos and updates regularly. He lives with his wife, his daughter, and his dog. To put it lightly, they are dog tired of his workaholism. Friends, I invite Dr. Tushar Shah to take charge of the panel discussion. Dr. Tushar Shah, please.
Hello, everybody. I first of all hope that all of you can hear me. I'm asked to do a short introduction of the second wave, so to speak, and then I'll be open to questions from you regarding day-to-day outpatient management of COVID-19. We are discussing outpatient management only, not indoor management. First, about the second wave. I believe the second wave has gripped India, especially Maharashtra and Mumbai, very strongly because of two reasons. The first reason is the mutation of the virus. The double mutant, so-called double mutant, may be responsible. And the second reason is the unlocking. And the unlocking includes the crowds at the vaccination centers, which have contributed to a large increase in the numbers that we see. The numbers are alarming because they are much more than the October peak that we saw, and there is no respite yet. And I do believe that we are going to see even worse in the next few days. And it is scary because people get scared, and sometimes genuinely so, because there are no beds available in most hospitals. And we might even run out of oxygen. There is remdesivir in short supply. And I think we'll be in trouble if this continues to increase. So I have requested all my patients to go into a personal lockdown so that, and not wait for the government to put a curb on going out of your bubble. So decrease your bubble size and just go on a personal lockdown. And of course, mask. In fact, I'm saying that the variants are for double masking. That is the variation that you have to apply. Double masking has become more important than ever before. About the treatment, as Dr. Zarir succinctly put, we have to abandon treatment which is useless, because you not only cause side effects, you're going to waste a lot of drugs for future use. Azithromycin resistance will increase tremendously because of such rampant misuse. Don't use doxycycline, don't use ivermectin, and favipiravir, which I have personally used in more than 300 patients. Last year, I have completely abandoned because I can realize that it is no better than a placebo. People often ask me, "Agar kuch nahi denge to denge kya?" And in my experience, because I've treated thousands of patients personally with the help of my assistants, thousands, I'm not exaggerating, I have convinced each one of them, I have not seen anybody abandon me, each one of them, that you have to rely on your body's immunity 90% of the times. That will work more than anything else. So do not be prone to taking by way of panic things. We know that relatives force you to do a CT scan when it's not necessary, to do IL-6 and ferritin when it's not necessary. They force you. I mean, all kinds of things are happening. A lot of it is doctors' faults, a lot of it is patients' faults, and we have to rectify this. I'm extremely upset that our learning curve is slow and our unlearning curve is even slower. I'm also upset that despite what Dr. Zarir has clearly mentioned, the task force of Maharashtra still recommends favipiravir in patients of COVID. I think they are forced by the fact that something has to be done. And that is a very sad thing, because you're spending a lot of money behind wasteful drugs. where important drugs like anticoagulants and steroids can be procured for more patients. So in the OPD, basically, what do you do and how do you decide when to hospitalize a patient, on when to become more aggressive? The first thing to remember is remdesivir is most useful within 1 week and extremely useful within 3 days. That you must take as a dictum. There are no trials to show survival benefit of remdesivir because there are no trials done to compare 72-hour remdesivir with 10-day or 15-day remdesivir. In the West, remdesivir is still reserved for hypoxics, which is nonsensical, which goes against all logic. And I don't know when will we learn to do either trials or just apply the basic common sense that antivirals will work within 72 hours if given properly. This applies for herpes, this applies for influenza, and this has to apply for COVID. So how does a family physician decide that this patient has to be pushed for remdesivir? That is the most important thing that I would like to teach you today. Remdesivir is useful in patients who are unlikely to benefit with passive therapy, or those who have a greater propensity for significant morbidity. So who are these patients? 70-year-old male who's a diabetic obese presents to you with 102 fever on the 2nd or 3rd day of COVID and a CRP of 25. The patient's oxygen is normal. The CT scan is not done because it's only the 3rd day. You have to go by fever, which is high grade, CRP, which is high, age, high, and comorbidity. This patient who's come to you on the 3rd day is swab positive. Please give remdesivir. Push them to remdesivir. You must do that. So similarly, you get a lot of such cases. Young patient with 103, we do know that we are seeing high grade fever in this second wave. Young patient with 103 fever on 2nd day. No comorbidities. Do not push for remdesivir. Do not give favipiravir. Do not do anything. Let the body's immunity take care of this patient. But a patient who has comorbidities, encourage them. Maybe 3rd day you tell them, 4th or 5th day, they will go for remdesivir. Remember, if on the 5th day, such a patient with comorbidities who deserves remdesivir undergoes a CT scan recommended by you or others and shows a score of 6/25, do not feel comfortable just because the score is less. Remember, every day of fever will increase the score of CT severity. It will 6/25 has to be judged by the day of fever. 6/25 on 11th day of fever is different and milder than 6/25 on 5th day of fever. So don't feel a false sense of security if the CT score is less on the 5th day. So basically go by clinical judgment, maybe go by CRP, and of course go by comorbidities and get the patient on remdesivir early. I have started, because there are no beds, I have started giving remdesivir at home, with first dose being given in the hospital. Now, this is a practice done widely in various semi-urban centers where patients are fleeced by doctors, charged several thousand rupees per day for remdesivir. I also know that there is no recommendation, and I don't know whether we are doing something which goes against law. But we are talking about patients' lives, and I really don't care about medical legal in this pandemic to this extent that I will deprive a patient from remdesivir. So I will give remdesivir first dose in the hospital, and next dose is at home. Send a nurse from my side and give for 4 more days. This is what I would do. Admit the patient when the patient becomes hypoxic. Hypoxic patients will not be treated at home, but non-hypoxic early remdesivir patients can be and should be treated if and only if a bed is not available for them. Another problem with getting a bed is once I put the patient in a hospital where I have no control, I see that the prescription goes haywire. You have all seen prescriptions of big hospitals, major hospitals, pulmonologists, even cardiologists treat, endocrinologists treat, everybody treats. But you see the antibiotics are started on day one without reason. Steroids are started without hypoxia within the first week. A lot of wrong happens, and that I cannot tolerate. I cannot tolerate patients being given steroids wrongly, because steroids given when viremia is rampant, you will only worsen the state of the patient while suppressing fever. Fever will be suppressed, patients will have a false sense of security, and you are only causing more COVID pneumonia. So push for remdesivir, my first message, in patients with comorbidities and in those who are early in their disease. So the corollary is that every patient who presents with fever today that even remotely looks like COVID, get a swab done on day one. You can't give remdesivir without a swab. You can't get a CT scan before 4th or 5th day. How will you push remdesivir if you don't have proof? Must get a swab on day one if the patient has comorbidities. Principle, every patient who's 60 plus or every patient who has comorbidities, get swab and get routine blood tests done. You can get as minimum as CBC and CRP done. CBC, CRP, D-dimer, random blood sugar, SGPT are my regular, and creatinine are my regular prescription for everybody who's 60 or more. But you do your choice of tests, but test everybody who's 60 plus without comorbidities, or anybody with comorbidities, test on day one with RT-PCR and get in your remdesivir early. First message. Second message is about steroids. Steroids are a brilliant drug for COVID, for saving lives. The only drug that has saved, I don't know how many, tens of thousands of lives. And steroid is the only drug that has killed thousands of patients of COVID. It is a double-edged sword. We must not misuse steroids. Family physicians, consulting physicians, everybody is to blame. Very clearly, steroids are to be judged, to be given with good judgment. And that good judgment, unfortunately, has not been learned in 1 year of COVID, which is shameful on our whole community. We are put to shame by our colleagues who give wrong steroids. Please don't give steroids. Antibiotics are one thing. Steroids are another level of mistake. Reserve steroids, not for any fever, but reserve steroids for hospital use in hypoxic patients. And if you have to give in OPD patients, wait for 7 days to pass, wait for high fever to appear, wait for CT score to go high, wait for CRPs to go high. It is a difficult decision to start steroids in the OPD. It is an easy prescription to write. It is an easy prescription for the patient to accept, because in 1 day the fever goes away. But it is a difficult thing. I stress over steroid use in the OPD. I would like you to believe me when I say that I've used oral steroids in non-hypoxic OPD patients in a total number of 6 or 7 cases in these thousands of patients I have treated in the OPD. You cannot give steroids without reason. We have doctors who have developed mucormycosis, secondary fungal infection, staphylococcal infection. Everything has become more common. Diabetes just goes haywire because as it is, COVID causes increase in hyperglycemia. You are doing harm, and such harm that Jahannam mein bhi jagah nahi milegi. Aisa nahi karna. Please don't do this when you give. Antibiotics is the third area which I am very stressed about and distressed about. Antibiotic use, azithromycin, doxycycline, has to stop completely. Don't make 2 excuses. Secondary infection ko prevent kar raha hu. Second excuse, azithromycin has in vitro studies like ivermectin, like doxycycline, in vitro studies has shown efficacy. Nonsense. Don't believe just because you have to give something. Don't believe on such nonsensical reports or studies which tell you that in vitro this works or that works. Please don't give azithromycin. Period. Reserve it. We need it for atypical pneumonia, for enteric fever, for venereal diseases. We need azithromycin for our children. Don't spend azithromycin on COVID. Well, this is my initial talk. Now I will open it to the public.
Yeah, Jawahar.
Thank you, Dr. Tushar Shah. Dr. Bharat Bhatt. Dr. Bharat Bhatt.
He's not there.
There.
Yeah. Sorry, I have no question. Sorry. Yeah.
Okay. So I will throw open the floor to questions from all the participants. I think Dr. Preeti Shankar can start first.
Yeah. Thank you, Dr. Tushar. You have already answered some questions. You have really given a lot of take-home points. One of my questions is already answered, role of steroids in home quarantine patients. I want to know the role of antithrombotics in patient mild to moderate cases who are under home care. Antithrombotics when and if at all.
That is an excellent question to which I have no satisfactory answer. The standard recommendation all over the world is all admitted or hospitalized patients must get prophylactic anticoagulants. That is the standard across the world, no controversy there. So enoxaparin 0.4 is given to everybody who's hospitalized. What about those who are at home? What about those who have comorbidities, are obese, are aged? Their D-dimer may be 600, 700 or even normal. Don't you give everybody, if you give it everybody in hospitalized, because in hospital, not everybody has a high D-dimer and we still give it. What do you do with OPD? I have struggled with the question. Only today morning, I asked Dr. Kumar, please break your head over this. Please look at literature. I have scored, I've seen as much literature as possible without any benefit. So I will tell you what I do empirically. Now this is empiric, my opinion, completely controversial. You can reject it outright. This is what I do. If the patient is elderly and has comorbidities, and if the D-dimer is 500 to 1000, I put them on a prophylactic dose of a NOAC. If the patient has 1000 to 2000, I use an intermediate dose. And if the patient has 2000 or more, is not being hospitalized for some reason, I put them on a full dose of oral anticoagulants. Sorry. Now, if the patient has been discharged from the hospital on anticoagulants, if the patient has documented TVT or pulmonary thrombosis, 3 months is the standard recommendation for anticoagulants orally. If the patient has been discharged on anticoagulants without any evidence of thrombosis, and if the patient has no clinical evidence of DVT, and if the patient has been continued on anticoagulants orally after discharge, I will wait for the D-dimer to go below 500 to stop the anticoagulants. That is my general policy. Again, it's a general guideline and I have no real backup scientifically.
My second question is, what are your views on fluoxamine? We do hear some studies and reports these days.
So my views on fluoxamine are the same as my views on intravenous vitamin C and intravenous glutathione and methylene blue and coronil and inhaled cyclosonide. My views are the same. Please don't solitary studies. Everybody gets excited about their own ideas. You know, Bangladeshi fellow wakes up in the morning with ivermectin and doxycycline in his brain and starts a study. Don't believe in such small studies.
That is why I asked the question to you. You're the expert. Thank you.
I hope I'm not an expert in these things.
Dr. Tushar, we are still waiting for your Lijjat Papad study, by the way. So.
I'd forgotten about it. I'll have to conduct it. No question.
I want to know.
That's why I'm reminding you. I'm reminding you.
Dr. Gwalani.
Dr. Rajni Gwalani, please.
Yeah.
Okay.
Good afternoon, sir.
Thank you, sir.
Most of my questions are taken care by your talk. I would like to know what is the difference in the presentation of symptoms in the present scenario compared to the presentation earlier?
A very interesting question because I'm still grappling with the new scenario. The first scenario is that, as you know, younger people are getting infected more. That everybody knows. School children, young people, everybody knows that. Much more symptomatic infection in the young. We may have had asymptomatic in the young more, much more symptomatic. And this symptomatic includes higher fever, more flu-like. You know, I used to fight that term, influenza-like illness. in the beginning because it was not influenza-like. But now you will see runny nose, coryza, nose block, more cough, more body ache, more constitutional symptoms, more rigors, higher fever in younger people. So that I'm seeing definitely. And influenza and COVID have become so much more difficult to differentiate clinically. They used to be much easier. But as Dr. Zari said, we should not suspect influenza currently. We have to suspect COVID in all such cases. So yes, that is one symptom. Secondly, I think, now this is an initial judgment, and I think I'll be proven right. I think severity has increased, not just infectivity. We all know that all of us have experienced that infectivity has increased with this whatever mutation there is. But severity has increased, and that is something that will probably come out in the next few days itself. And I'm very upset about that because more patients, younger patients, are getting more severe disease and more hypoxia, and that is going to trouble us tremendously, and that is going to also make us make mistakes more commonly. That hopefully should not happen. Sorry, yeah, I'm done. Sorry, yeah.
Dr. Bhairavi.
Dr. Gwalani can finish one more question. And then
I'm seeing a lot of patients with vertigo and just giddiness out of the blue. And then because you have the doubt that he's not COVID and they turn out to be COVID positive. So could you tell something on that?
One thing I have always insisted upon is anecdotes should not become evidence. We will all have our own anecdotes to state, our own feelings. And the bias that we all have, we have to learn how to limit our biases. So we must not generalize something that has occurred in one or two patients. I'm sure you must have seen many cases of vertigo. I have not seen, but this will keep happening with all of us. We'll see different things, and we'll therefore believe it because we have seen it. Let it become a generalized view.
Okay, thank you, sir.
Sir, many of our patients have complaint of cough. Some have cough with expectoration and some have dry cough. So what do you suggest for patient having cough?
If you're asking me what treatment I suggest for a patient having cough, that is the most difficult symptom to treat and the most effective treatment of cough, the hacking cough that some patients get. The most effective treatment is steroids. And therefore the temptation to start steroids early becomes a harmful temptation. Otherwise, symptomatic drugs, I rely most on codeine, which is not easily available. Most other things that I've tried, dextromethorphan and the newer antitussives, I have found little use or no use at all. So I do tell patients to do their gharelu ilaj, home remedies. They are very happy when I tell them about home remedies and honey and haldi and things like that. And that's all. They just have to wait it out for the cough, whether it is with sputum or not. Please remember, I know that this question also comes from the fact that you are tempted to use antibiotics when sputum occurs, right? Please resist that temptation. That is very important. Resist temptation. You are reducing appetite, causing nausea, causing diarrhea in an already sick patient by giving antibiotics. Expectoration becomes an excuse for giving antibiotics. Don't let that be an excuse. If you get a greenish expectoration, you may, then I will excuse that temptation taking effect. Otherwise, thank you.
Many of our patients also have fever lasting for 7th, 8th, even 10th day. Though the range is 9900, not high. So do you think it is because of corona itself or should we check for other infection?
Yeah. Again, a temptation to start antibiotics. I'm sure that temptation is very severe, very strong temptation to start antibiotics. I'll tell you one thing about prolonged fever. This is a very important question, and this is a very good question. Prolonged fever in COVID. One prolonged fever is the prolonged fever that is not associated with significant constitutional symptoms like weakness, like anorexia, like lethargy, like increasing cough. You will see many patients who have just fever and they say कि वो तो मैं नापता हूँ तो पता चलता है कि fever है, नहीं तो मुझे कुछ भी नहीं है. This patient has to be left alone. Don't give steroids. Don't give antibiotics. This patient can be left alone if the CRP is not rising, if the patient has no other symptoms like increasing cough. we have seen, as I've said often before, we have seen 4 weeks of fever, and this stands true today also. 4 weeks of low-grade fever persists. I have to convince the patient, please don't start unnecessary drugs. How do I convince them? I tell them, this is your body trying to create more antibody production. This is just your immune response to the virus. It is just a fight happening, a small battle happening. Let the battle be won by your fever. So that is one type of prolonged fever. That is one. Second type of prolonged fever is an escalating fever. Fever that is 99, 100, 101, 102, step ladder rise, on 7th day becomes 102. Now this is bad fever. This is fever that will require something, some intervention. This is fever that will lead to a largish COVID pneumonia with a large CT severity score, with a large, strong chance of hypoxia. This fever, a rising fever, even in a 45-year-old, should be treated aggressively. When I say aggressively, I will mean start remdesivir within 7 days if you can. My remdesivir limit is 10 days. Before 10 days, I don't, what's that called? My limit for remdesivir is 10th day of onset of fever. Ideal 7 days, very ideal 3 days is my classification of remdesivir timing. So if the escalating fever prolonged, there's no question. You can't. So for example, I'll just give you another example. A 60-year-old has fever of 100, 100, 100, 100, and then 5th day it goes to 101. Now this patient who has comorbidities or age, if the fever goes up a bit on day 5, I will insist on remdesivir. I will not say, okay, let's wait, let's change give one more antibiotic, give augmentin. I will not do that. My main argument against favipiravir is that it wastes time. Once we start favipiravir, even if you start it on day 2 or day 3, you will tend to wait for a few days, for example, 7 days, till the favipiravir effect is seen. And you will see that the fever has not responded to favipiravir and you will be in a soup because you wasted time. So that is my main argument against favipiravir. No evidence, that is one thing. Favipiravir, despite the fact that favipiravir has been introduced 8 months plus back, remember, not a single study in any country has come up with a utility for favipiravir. That says something. Lack of evidence is good evidence. It is evidence that it does not work. Dr. Zarir himself conducted a small study for Glenmark, which showed that it does not improve survival, but it improves the duration of fever. After that, that small study, after that, no study. They have tried a stage 3 trial, or a double-blinded trial. It has gone under the carpet, obviously, because the results were not good. They will not publish a bad study because it's a $1 billion product. So you have to realize that a lack of study coming out means that it does not work. If you think if Glenmark or the Japanese company which initially started this, if they had evidence, it would have been published by now. It's such a huge market for favipiravir. But no, so favipiravir has to be thrown out. I have used it. I know that I have been giving it wrongly, but I have to unlearn. I have to stop favipiravir. Period.
Sir, have you used naproxen for fever?
Mefenamic acid, naproxen, even brufen are favorite drugs. I have completely desisted from using NSAIDs for fever in COVID. I tell patients, you know how Dr. Ram Murthy used to teach us, and Dr. Amdekar still teaches us, that fever is not a problem. Fever is not a disease. Fever is the body's response. You don't have to treat fever. You have to treat the cause of fever. And therefore, just to satisfy the patient, don't treat the fever with stronger drugs. Steroids, NSAIDs, all come in the same category. You don't use them for fever. Steroids will be used for COVID pneumonia, not for fever. So I convince the patient by telling them that tolerate fever, and just wait it out. You will have to do that unless you want more side effects. NSAIDs can cause many more side effects. Why do you want to give a drug that is thrombotic? You don't want to give a drug that is nephrotoxic. Why do you want to give a drug that is GI toxic? I don't want to use. Myocardial infarctions can occur due to NSAIDs. And you know that myocardial infarctions have been a rare complication of COVID. Why do you want that to happen?
Dr. Rajiv Shah.
Hi, sir.
Hi.
How many patients in your experience have suffered a cerebrovascular accident or MI in the 3 months post-COVID?
Two.
Hello.
Maybe two myocardial infarctions, and I could not correlate them. Maybe two. As Dr. Zarir said, maybe the antiplatelets were stopped by them. None under my care. None who died. 8 patients have died under my care, direct under my care, and none of them due to myocardial infarction or strokes. None of them even due to, one patient had atrial fibrillation because of myocarditis. Very elderly patient.
battery dies.
Dr. Bhairavi Shah.
I will take 1 more second. Dr. Rajiv's question. This is but sir, जरा mic off कर दो.
Yes.
Another why anecdotal bias has to be eliminated. You see one patient of myocardial infarction in COVID in your practice, and you start giving ecospirin to every patient. Don't do that. Ecospirin has no evidence. There's a trial going on for aspirin in UK. Let that result come. But aspirin is not indicated as a primary prophylaxis for MI or stroke in COVID. Very important. In fact, if the patient is on dual antiplatelets and the patient may require hospitalization, I will remove one antiplatelet if more than 1 year has passed since angioplasty, because the patient may be put on NOACs or Clexane. So I will not put any patient on aspirin, however much the temptation is, because there is no evidence. Again, you are going by evidence. That is most important. Yeah.
Sir, second question. Sir, should we test everybody in the family once one member tests positive?
Yes. The government will come after you. The government will say, तुमने मेरा 8,000 केस का 10,000 बना दिया है, तुमने ऐसा क्यों किया? No, I'm just joking. You must test every adult in the family, definitely. And except very small children like 4-year-olds, I would test everybody, but every adult is a must. What I do is I presume every youngster is infected in the family. If there is one person infected, I presume that and isolate them accordingly. Every adult I will test. Why will I test every adult? If they worsen and need hospital admission, I would be ready with an RT-PCR for that purpose at least.
So one more question. Sir, now since the last 5 days, the result of RT-PCR is really delayed to more than 48 hours. Shall we do both so that we know, because I'm doing the antigen, I get it positive, I wait for the RT-PCR, but at least I know that this person is positive. So I do both.
I do think that that's a very wise thing that you do. Do the rapid antigen and the RT-PCR together, very wise. Also start presuming COVID. Start presuming that this is COVID. Dr. Jawahar, I remember, was talking about, should we presume every fever to be COVID? And why is there a mistake that we make? Of course, if we cannot do that, because we will miss. So a good clinical history has to be the premise of diagnosing COVID. A good contact history has to be a premise for diagnosing COVID. But presume COVID if there is a small evidence of contact or symptomatology. And therefore, isolate the patient accordingly. And of course, do the rapid antigen. If you have to admit a patient for remdesivir and you can't wait for 72 hours for the test report, then a rapid antigen makes great sense to start remdesivir. Of course, with the caveat that it will not show 50% of cases.
Thank you, sir.
Thank you, Raj.
Dr. Shukla.
Sir, which investigation you advise?
Please wait. Dr. Shukla is asking.
Thank you, sir, for coming here in your extremely busy schedule. Sir, I wanted to ask again about, so I actually wanted to ask you about steroids and antibiotics both after day 7, because a lot of pulmonologists are giving steroids after day 7. But you have, I think, answered that. And about antibiotics, I wanted to ask you that beyond day 7, is there any role if the total leukocyte count is normal?
Yeah, so day 7 and antibiotics, pulmonologists. One thing is I have started distrusting pulmonologists. It is a shameful thing for me to say, but I have seen so many prescriptions of ivermectin, doxycycline happening from pulmonologists that I'm a little ashamed of the whole community of pulmonologists. Not a single pulmonologist is like Dr. Giri. Why are they not just following him? He's a great person to follow. He's a pulmonologist. Please follow him if you can't do the correct thing yourself. That is one. I know that I sound a little aggressive when I talk, but it is frustrating that we are doing so much harm to the public. Our priority is not us. Our priority is the patient. You have to first think of the patient. That is such a simple thing as when you're a doctor. Okay, so after 7 days, for example, when a patient gets admitted under my care, about out of every 100 patients that I admit, about 30 will go on antibiotics. Secondary infection does occur in severe COVID, where the lung is bad, the lung takes bacteria. What criterion do we use to start antibiotics? The most important criterion we use is areas of consolidation on CT scan or X-ray test. We will think of starting antibiotics. A dense consolidation, not that round glass, transparent consolidation. Second is the CRP, a very high CRP, 120 CRP, can be either secondary infection or a cytokine storm or an impending cytokine storm. If you can judge whether this is which one of these, then I would give an antibiotic. Procalcitonin will make us give an antibiotic if procalcitonin is high. So those criteria we use in indoor patients. In the outpatient, just because the patient is 7 days old, do not give antibiotics. In the outpatient, give antibiotics. The patient frankly complains with copious, purulent, or foul-smelling expectoration. Then you give antibiotics. Then it is secondary infection. There might be a coexisting infection of sinusitis with COVID. You can have that. So think of coexisting, but don't think of prophylactic antibiotics just because it's 7 days. About what is the second question? Steroids after 7 days. Again, choose wisely. Steroids are very useful in patients in some rare situations, unless there is hypoxia. Hypoxic patient, steroids, no-brainer. All hypoxic patients must receive steroids. If they are not getting a hospital bed, they must receive steroids at home till they get a bed. All hypoxic patients at home must be started on steroids and on anticoagulants, definitely on remdesivir if they are within the time frame. That is a no-brainer. But if the patient does not have hypoxia, remember, patient has escalating severe cough, patient has escalating CRP after 7 days, escalating fever after 7 days, and also signs of viremia have declined. What is the principal sign of viremia? Lymphopenia is a principal sign of viremia. If lymphopenia has corrected itself, then you can be brave enough to do steroids. Remember in the back of mind, mucormycosis, fungal infections of other sorts, secondary staphylococcal, they can kill, and therefore you will be responsible for that death. Remember that and be very, very conservative in giving steroids.
Okay, thank you, sir.
It will help, sir.
Dr. Adhwari has a hand raised, I can see.
Yeah, I wanted to ask that if a patient has got normal neutrophilic count and he develops neutrophilic leukocytosis, can we take that as a marker also in OPD basis or not?
When you say neutrophilic leukocytosis, you are probably talking about a count of say 12,000 with 80% or 90% neutrophils. Yes, then you should take that. Remember, in that situation, the lymphocyte count, NLR will be high, 90% neutrophils, 10% lymphocytes, but the absolute lymphocyte count will be more than 1,000. So it will not be lymphopenia, it will be pure neutrophilia, and you may, in clinical correlation, consider giving antibiotics in such patients. But also remember, steroids cause a high WBC count, high neutrophilia. Many patients will come to you because of having already taken steroids. There are patients who start them on their own. So just take care of taking a proper history, whether the patient has taken steroids, and that is the cause of the leukocytosis.
Thank you, sir.
Dr. Meeta Kala has hand raised.
Yes, sir. So I wanted to ask whether after giving a remdesivir, what symptoms we should observe, and when to do the next set of test after 2 days, 3 days, what test to monitor?
Yeah, so my protocol, which of giving remdesivir, if I'm giving it at home, is first day, go to the hospital, take remdesivir, do an ECG after remdesivir, document that there is no bradycardia, which is one uncommon or rare side effect of remdesivir. Of course, watch for vomiting, nausea, etc. The next dose, etc., you will give at home on after 3 doses, that is after 400 milligrams of remdesivir. First dose is 200, then 200, then 100. I will do, the two main side effects are on the kidney and on the liver. I will do creatinine and SGPT mandatorily, or creatinine and SGPT to watch for the side effects. And I will do the CBC CRP if I'm monitoring the patient for COVID. So these 4 tests, CBC CRP, maybe D-dimer, creatinine, SGPT, on the 4th day.
Okay, thank you. And sir, asymptomatic D-dimer raise, how often you repeat D-dimer? Suppose patient is elderly, above 60, and he has D-dimer of 750, but he doesn't have any symptoms. Even clinically, he is okay. So then how often to repeat?
In the absence of symptoms, I will mostly ignore the D-dimer of even 1000. If it is more than that, I will repeat a D-dimer in another lab. D-dimer is a big problem with laboratory. Laboratories have errors which are aplenty with D-dimer and IL-6. Major problems in pathology labs. So you will repeat D-dimer. If you get a consistently high D-dimer, then you will take a clinical judgment. I have not started a single patient anticoagulants if they are asymptomatic otherwise of COVID.
Sir, how long to continue nintedanib and Perfinex after the research?
So first of all, I'm not the best person to ask this question because I'm not a pulmonologist, and I would refer a patient of such situation to a pulmonologist. Secondly, I do know that nintedanib and remdesivir both have no proven benefit. No scientific study has shown proven benefit. And again, I know that patients are started on both drugs often together. And the defense is the one is not tolerated, one nintedanib causes diarrhea, and the other drug causes nausea, vomiting, anorexia. So small doses of both can be combined. Now this is all empirical. And currently I have not put a single patient myself on nintedanib. And I do believe that we can't do anything if fibrosis has to occur. And I do believe that fibrosis, which is permanent and disabling, is extremely uncommon.
Thank you, sir.
Sir, how safe is giving remdesivir at home? Like you said, first you should give it in the hospital. So what reaction you expect if in the hospital?
Okay, unfortunately, what happened just recently with my patients is a particular batch of remdesivir from a very good company, a particular batch number 18, caused four patients to have rigors, 3 in the hospital, 1 at home, on 1 day. And we found that luckily no harm was done. And we of course, recalled the batch. We have forced the company to recall the whole batch of 30,000 vials of remdesivir. And so this is something that can happen. At home, rigors due to IV infusion would be your most important worry. So after this incident, what I have started is I will give IV Avil to every patient who I give first dose of remdesivir, and just hope. Again, as I said, we are not doing the ideal thing by giving remdesivir at home. We are just preventing, we are just doing it because we can't admit the patient in a hospital which we trust. And therefore, we have to take maximum. So first dose definitely in the hospital. I would like the ideal situation to be patient goes for every dose to the hospital. That is the ideal situation to happen. Every dose, all 5 days a day. Maybe I will convert to that. Once yesterday, मैं थोड़ा हिल गया, 4 patient को राय कराया तो, लेकिन I might do that. I might insist on every dose to be taken in the hospital. For the family physician, this is the problem. You have to get hold of a hospital where the consultant is amenable to your suggestion of giving remdesivir. Now, that is a difficult thing for you. I know that. So I don't know how you will handle this situation.
Is it legal? You can give remdesivir?
I don't know if it's legal to give azithromycin. Nobody questions that. Nobody questions that legality. Steroids in the first week. Nobody questions that.
We thought it is given only in hospital setup. You cannot give at home.
So
this is the first. Last year we heard that way, and I have not seen any doctor giving or any consultant giving patient at home remdesivir at home.
I just
First
gave
time
it
I'm
yesterday.
hearing. Yeah.
They are giving. Many people are giving.
Yeah.
Yes.
Yeah, I just gave it
Especially
yesterday.
out of Mumbai. Out of Mumbai, many people are giving.
Yeah, I think Dr. Meeta gave it yesterday to her father. Who gave it yesterday to her father?
Yes, I gave it to my father yesterday.
I know. You are brave. I'm glad that you gave it because he was not getting a bed. And yeah, but I do hope that your father was not agreeing to hospitalization, right?
No, he was agreeing to hospital, but there was no bed available, sir. And RT-PCR is still awaited. We got rapid antigen test, which is positive. So,
yeah. So this situation come up. Just to answer that one question again, remdesivir at home, is it legal? Now, I have not found any place where it is said it is illegal or that it cannot be used at home. I have not found it anywhere else. So I presume that you are doing something for the good of the patient, and I don't think any court of law will punish you for that.
Sir, which investigation you advise to COVID patient and on which day?
Excellent question. And a question that we should at least standardize within our family physician community. We must standardize this situation because again, things happen and patients, are doing investigations on their own. So we must curb that. So if once I suspect COVID, I will do the RT-PCR. I will do CBC, CRP. I have still tended to do D-dimer in all patients who are symptomatic. So CBC, CRP, D-dimer. I will do creatinine, blood sugar random, and I will do an SGPT for baseline because if remdesivir is given, you need a baseline SGPT. I will do these basic tests in all patients: CBC, CRP, D-dimer, SGPT, random blood sugar, creatinine. I'll do these tests in all patients who are symptomatic and deserve investigation. Now, this is very important. What investigation to do is one thing. In which patient to investigate is another thing. If a 30-year-old comes to me with 101 fever on day 1, 102 on day 2, what do I do? Do I test? Except RT-PCR, of course. Do I do blood tests? I don't. I don't do blood tests in the young people. Period. I don't test them for CBC, CRP. I know that young people will recover beautifully, unremarkable. No chance of hospitalization in most situations. If they are below 30, definitely no. You can't put
pregnant women.
Pregnant women, our experience in Mumbai is that they are not more prone to morbidity. But pregnant women, I would test. You are right. But young people, otherwise, I would not do any blood test. 30, below 30, definitely no. Even probably below 35, I will not test. So below 40 is a gray, 30 to 40 is a gray zone where I will test in individual basis. But below 30, I will not test. So what happens, as you know, is they get tests on their own. They will get IL-6. Normal 7 दिखाता है और किसी का 35 आता है, so there is panic all over. And we do know that IL-6 up to 10 times upper limit should be ignored. You have to ignore IL-6 up to 10 times upper limit of normal. You have to ignore ferritin up to 5-10 times upper limit of normal. Ferritin of 1000 is of no sense, no importance at all. Don't dissuade them from doing tests. And in fact, I have WhatsApp message to them. If you do IL-6 or D-dimer, you will panic. Sorry, IL-6 or ferritin, you will panic unnecessarily. Don't panic. So yeah, that is the lab investigation that I'll do, and in whom I will do. And how often you said you repeat the investigation? Again, this is subjective. You will repeat the investigation in patients on remdesivir differently, patients with high-grade fever separately. You will decide that. If you see a rising trend in CRP, you can even do CRP every day, for example. So you will be very subjective. Yeah.
So such patients, not even CBC and CRP as a baseline level to be compared with subsequent days.
I'm hoping that you're asking for a young patient, 25 years old,
yes.
And you said, so I object to that. One, where will they go for collection? They will call a lab person home. You are already overloading the labs with work. Labs don't have enough technology. If the patient goes out, you're exposing others to that patient who's going out. You can't investigate unnecessarily. You're putting a load, both mental and infective load on the community by doing this. So don't investigate. Very important. Convince the patient. The patient wants to be investigated. The patient is keen to do everything. But you have to dissuade them.
Dr. Tushar, have you observed increasing thyroid dysfunctions in some of these patients, especially acute thyroiditis cases?
Hormonal, you said hormonal, your voice broke in between, but you said endocrine disturbances?
Is there an increasing thyroid dysfunction in these COVID patients and acute thyroiditis incidence?
Thyroid.
Yeah. No, meaning I have not seen, and I would again not. I don't think I have literature to go back on. I have not read anything about it, but I have not seen, because I would have noticed, I think, if there was some correlation. Yeah, Dr. Gwalani.
Yeah, if a patient is COVID positive and non-hypertensive earlier and becomes hypertensive, what is your drug of choice to give to the hypertension during COVID positivity?
Good question.
So people have debated whether ACE inhibitors are to be given, where ACE receptors are the entry mode, etc. I don't think there is any evidence against ACE inhibitors. My choice is between amlodipine and ACE inhibitors. If a patient is a diabetic not taking telmisartan or some such drug, then patient on telmisartan and hopefully continue it for life. More important, I think, is the question of diabetes. So this is some area that family physician has to be more proactive in terms of that. Every diabetic patient, if they get COVID, first of all, they must buy a glucometer. Second of all, they must do their fasting PP or whatever values you want immediately. And you must step up their dose of diabetes medicines. That is one thing. Which drug to step up? Insulin resistance is a problem in COVID. You must step up metformin, even though it is said that sick patients should not get metformin. But in COVID, metformin is the most important anti-diabetic. That is the second. Third, many COVID patients who are diabetic are on SGLT2 inhibitor. You must stop their SGLT2 inhibitor. Must stop it completely and step up the other drugs to control the diabetes better. The reason for stoppage is, of course, dehydration that will occur with COVID. In hypertension, you must stop diuretic. So Telma CT has to become Telma plain, etc. Hydrochlorothiazide, chlorthalidone, or even loop diuretics. Unless the patient is taking them for failure, you have to consider stopping all diuretics.
And if a patient of COVID positive, he gets his attack of migraine and he's on naproxen and all, he can take it, no, or not? During COVID, if he has an attack of migraine.
Very good question. And I mean, this is an anecdotal thing that you will probably corroborate. Migraine patients, when they get COVID, get severe exacerbations of migraine. Is our observation limited to a handful of patients, but their headache just simply refuses to go. This is what we have observed. Pre-existing migraine, now COVID, bad migraine is what we have observed. I would hope you will give me some feedback in your own experience. Such patients, I give naproxen. such patients are such unbearable headaches that I'm forced to give naproxen. I give naproxen.
Sir, can I ask one?
Yes, sir. You are the boss.
Sir, yesterday I received a phone call from Raipur and the doctor wanted to use tocilizumab. So I just said, okay, now to we just forgotten about this drug. So I don't know, is there still a role of such drug in any situation?
Yeah, tocilizumab has now scientific evidence for saving lives.
Okay.
Scientific evidence for saving lives if used correctly. So, of course, as you know, last year, India was the largest user of tocilizumab in the world, with thousands and thousands of patients, many killed by tocilizumab. However, we now know that tocilizumab can save lives if used correctly in hospitalized, hypoxic, non-invasive or invasive ventilation needing patients. Tocilizumab is a drug for cytokine storm, and if used in cytokine storm, can save patients. I have had great experience with tocilizumab, and I have in 400 hospitalized patients, I have used it in 10 or 12. I know that doctors who have had 100 patients have used it in 50 in hospitalized patients. That is probably incorrect. But in those patients I've used, I've had unexpectedly good results. I cannot have a double-blind study at my end, but I'm very happy with tocilizumab if used correctly. Now that correct use is a very, very subjective thing. From person to person will change. But I know now that many intensivists are getting a hang of correctly using tocilizumab.
Thank you, sir. Thank you. Jawar?
I think, shall we wrap up? Any more questions?
एक last question, plasma accept कराए कि नहीं कराए?
Sorry, who is this?
Yeah,
Atul.
He's asking whether plasma transfusion, plasma, whatever donation, plasma, what is it called? Plasma?
Therapy.
Serum.
Therapy, whether it can be used or not. No, it cannot be used. First, most important, it cannot be used. Again, plasma is a tragedy. Plasma is a tragedy because all trials of plasma occurred much after the patient had gone into the immune phase, and plasma gave antibodies unnecessarily when there was no virus to kill by the antibodies. Plasma is an antiviral therapy. That is something that is mistaken. So why do hospitals prescribe plasma still in Mumbai? The reason is simple. They prescribe because they are forced to prescribe. The intensivist taking care of a patient who's on a ventilator has given remdesivir, has given steroids, has given tocilizumab, and the patient is not doing well. The lungs are all white, and the relatives have been told that the survival chances are negligible. And do something, doctor, do something, doctor, do something, doctor, will result in the doctor telling them, okay, get plasma. Now the ball is in the patient's court. They have to arrange plasma. Suddenly, the patient's relatives become the therapeuticians, providers of treatment. And that is an escape for the treating doctor from the patient's incessant requests. The patient is not wrong, and what happens is patient struggles. We used to have a plasma donation campaign in the beginning, which I dissociated myself from very early, and that campaign still provides plasma to patients, and patients get plasma, and then the patient dies, and the patient are satisfied that they did something in the end for their relative. And yeah, that's about it. That's the role of plasma. We know that plasma is the cause of escape by viruses and becoming mutants. We know that because what plasma does is introduces antibodies, exposing the virus to antibodies. This antibody titer is not enough to kill the virus, but it is enough for the virus to replicate in a dormant state slowly in the body. And in that dormant, slow replication, it finds mutations. These are called escape mutations. These mutations can, of course, harm all of us. So that is what plasma will do, if at all it does something for COVID. Yeah.
Dr. Delia? Dr. Delia wanted to ask a question. Dr. Delia, please unmute.
Unmute yourself.
Sir, in a family, one person is tested COVID positive, he goes in a room. On day 6, second person of the same family tests COVID positive, he goes in the same room. On day 11 of the first person, a third person enters the same room because he is COVID positive. And now the first person has become asymptomatic. He has been asymptomatic for 5 days now. Does he need to take any extra precautions before he leaves that room?
They will usually take a bath and come out. That's good enough. Nothing else to
Thank you, sir.
Dr.
Can I
Jawahar,
ask-
one last question.
Yeah, Dr. Preeti.
Jawahar, can
Yes,
I?
yes.
Dr. Tushar, I just would like to ask you, in your experience, people who have had reinfection, we know that it is happening now, and COVID in fully vaccinated cases, do you see any change in the severity in such cases?
Great question. I think I would like to talk 2 minutes here at the expense of wasting more time. We are seeing reinfections uncommonly, meaning but we are seeing them, meaning those who got COVID last July, June, May will now get COVID because their immunity has waned and they may not have been fully vaccinated. So they will get a second COVID attack. Will the COVID attack be less severe? Maybe, we don't know. Mutants can do anything. We don't really know what mutants are doing. So second attack of COVID will become more common as we go into the next few weeks. You will see multiple patients coming with second COVID. And these patients may or may not be more severe. We will learn as we go along. I believe now that this is a race, right? The race is virus versus
Vaccination.
Vaccine. Dr. Bharat's question.
But actually, it is a joint race to reach a target of herd immunity. Both virus is taking to the us to the herd immunity, and vaccine is taking to us to the herd immunity. Which contributes more or less is anybody's guess. But I do strongly believe that the way things are right now in Mumbai, where probably 1 lakh people are getting infected every day, probably only 8 or 9,000 reported cases, and if that is happening, the infection rate is so high that we are moving towards at least a localized herd immunity. You know, the kind we got in slums, like that kind of immunity we are moving towards. And the virus will take us there more than the vaccine will take us there, towards herd immunity. But which mutation will cause which third wave or what will happen, we don't know. But I think we are looking at a washout in 2021. We are losing 2021 completely. Pessimism, but I'm sorry. Yeah.
Okay.
I think we'll wrap up.
Severity cannot be predicted. That's what you.
No, as I said before also, I think severity will be more, not because of reinfection, but because of mutations. Severity will be more. But that is something that only in a few days we will know.
Thank you, sir. Thank you.
Thank you, Dr. Tushar Shah. I will ask Dr. Bharat Bhatt to give the vote of thanks, please.
Yeah, first of all, thank you, everybody. On behalf of Bombay Medical Union and C Ward Managing Committee, I thank all the participants, and my special thanks to 2 eloquent speakers, that is Dr. Zarir Udwadia and Dr. Tushar Shah. Again, I thank you for your elaborative and lucid talk and sparing your Sunday and making our Sunday bright in such a gloomy period. Again, I thank all participating associations, panelists, and participants, because of whom only this webinar is a big success. And again, a big thank you, everybody. Thank you.
Thank you, sir.
Thank you,
sir.
sir.
Thank you.
Thank you very much. Sir.
Thank you, everyone, for the interaction.
Thanks,
Very,
everyone.
very useful.
Jawahar, what was the count?
Sir, 1 minute. I have forgotten to mention the Award Medical Association, and Dr. Nisha Kushlani was there all the way. Thank you very much, and I am sorry for the thing. And the count is, I think, more than 1,000 we have seen on YouTube.
Look
Thank
at
you.
Bania in Duvario.